We know the stakes are high. Cardiovascular disease continues to be the #1 killer of Americans.
We have more options, we have more devices, but the disparities are persistent.
If a patient is stable on their medication, no matter what that medication is, let them stay on it.
Action happens when the public demands it.
The most powerful person in this room is the patient.
The patient-physician relationship is everything.
We just need to keep advocating for what is right.
Our goal is to take the experts who have devoted their lives to helping people with cardiovascular disease and elevate their voices in policy conversations at the state level and on Capitol Hill. Good morning, everybody. My name is Ryan Googe, and I'm the Executive Director of the Partnership to Advance Cardiovascular Health, or PATCH for short. First of all, it took everything in me to not make my entrance from the balcony up here and come out and yodel or something. Just such a missed opportunity. Thank you all so much for being here. We know that, post-pandemic, it's a huge time commitment to come to events like this. And so we really appreciate it. We're really grateful for your attendance. And for those who are watching online, thank you also for being here with us. We want you to feel like you could be a part of the program. And so if you look below the live stream, you'll see a Q&A box there. You could submit questions via that box, and they'll come to the monitors down here for our moderators, and we will get to those questions as best we can throughout the program. First of all, I want to thank our members. We have 17 member groups of the Partnership to Advance Cardiovascular Health. It doesn't cost anything to join. So if you represent a patient group that serves heart patients or a provider group, please find us after the program. We'd love for you to join PATCH and be a part of all the work that we're doing. I also want to quickly thank our team. Our team makes me look good up here, and I'm very grateful for that. But in particular, I want to thank Alexa Devantier, who is here in the back of the room. She's our Chief Logistics Officer, as I like to call her. Allison De Batista, I don't know where she is, but basically her job is to make sure that I don't have a cardiovascular event. She makes all the trains run on time. Andrew Roof. Andrew helps us with all of our communications work, a lot of the videos you see up here. Julia Machado, who crafts the best tweets in the game. Grateful for everything that she does. And also Chris Berger and Elise Johnson, who help us with all of our special projects, and this is definitely one. So one comment I want to make, and then I'll ask Dr. Patel to come up and give our opening. But I think there are two things that really make PATCH special as an organization. First of all, we try to collaborate with our partners as much as possible, and I hope that our partners feel that way about us. But we know that we can be better if we work together. And I have to say, whenever we're working on a policy issue in a state or here with the federal government, and I say, hey, I need a patient who kind of fits this profile, or I need an expert in this specific disease state, everyone always answers the call. And that's what makes this organization strong, and I appreciate so much the collaboration from our partners. But the second piece is also action. We try to take action on a daily, weekly basis on important issues that are moving through Congress or moving through state legislatures or moving with regulatory bodies. And in fact, we also try to lift the patient and the clinician voice in those debates. And so as part of that, you may not know this, but yesterday we actually did a training seminar with a number of patients who are here in the room with us today, and you'll get to see them later. And some will be on stage as panelists as well. And tomorrow, to the Take Action part, we're going to be going to the Hill. We have some specific asks to make. And so we're going to try to take this advocacy and put it into action. So with that, and I'll also say Dr. Patel and I are going to the Hill at 3:30, so we've got to wrap this thing. We've got a meeting with some senators. So I want to say finally, while I bring Dr. Patel up here, that none of this is possible without Dr. Dharmesh Patel. He, when we got this organization started in 2016, came and said, yeah, I'll be the board president, and has helped us grow this organization and make it really impactful. We couldn't do it without him, and I'm just honestly so grateful for your leadership and your friendship, Dr. Patel. And with that, I'll invite you to the stage for our opening comments.
Good morning, everybody. Just to put the record straight, Ryan demanded I was a president. He didn't ask me anything. I had no option. But good morning, everyone. I'm Dharmesh Patel. It's great to be with you all today. At every patch meeting, we open by talking about crossroads we face in cardiovascular medicine, and you all know the statistics. Cardiovascular disease still remains the #1 killer in the United States. Heart failure kills more people than all cancers put together every single year. 800,000 people die from strokes every single year. Stroke is the #1 cause of disability in this country. The number of people diagnosed with hypertrophic cardiomyopathy, peripheral artery disease, high blood pressure, high cholesterol, diabetes, kidney disease is increasing every single year as our patient population ages too. And every year, as a provider, we see new challenges in getting patients access to medicines and devices that they need and deserve. I see it every day in my clinic in Tennessee and in Mississippi. I know my colleagues in this room face that same challenge around the country. As Ryan said in the opening video, our mission at Patch is to lift the voices of the clinicians who have dedicated their lives to treating those with cardiovascular conditions. It is our belief that it is physicians, nurses, nurse practitioners, all clinicians know what is best for the patients that they are treating. Remember, when I see patients, not every single patient is the same. Every one of us is unique. We are living this daily battle, doing everything we can to help people. If we can take their expertise and lift it into the policy conversation, we believe healthcare will be better for it. As you heard me say in the video that was just played, I also believe that the most powerful voice in the room is the patient. When I started med school, I thought it was a patient-doctor conversation in a four-walled room. I'm finding out very quickly there's 3 people in this room now. It's myself, the patient, and access and insurance policy. Because at the end of the day, we can talk all day long about therapy, but if we can't get it to the patient, what's the point? That was off the script, by the way, just letting you know. Yeah. Okay. I have a very hard time keeping with the script, but I'm trying my best. Yeah. So, as a clinician, I speak to guidelines and best practices and the latest advances in medicine. But patients are why we are all here. Patients deserve the best care we can give them, and their experiences in the American healthcare system are invaluable. Again, it's for the first time. In 2010, we were doing a great job as cardiovascular disease was going down. And since 2010, cardiovascular mortality has been going up despite us having better treatment therapies today. I personally think that if we don't get this right, our country will go bankrupt in healthcare costs alone. They need to be lifted into the most important policy conversations, patients that is, we are having in this country. When a patient is willing to speak to their experience and take that to a state legislature or the halls of Congress or the media or a health plan, it is so incredibly powerful. We've seen it move policy for the improvement of patient care. And that's why I'm so excited that yesterday marked our first Cardiometabolic Leadership Academy. I met some of you earlier today. What a fantastic, inspirational group of people. And to the great honor of Ryan, Allison, and the whole Patch team, you gathered some of the nation's leading experts on access to medicine, and you completed a full day of training with 14 of these fantastic patients on everything there is to know about access to care. Our participants who are with us today Also had professional media training seminar so they can not only share their stories effectively, but weave in important policy topics for legislators and the media. It was a great program, and we really are looking forward to hearing from some of our freshly minted CLA participants today on stage. Finally, I want to speak to the importance of this meeting and the work we do all year at Patch. Access to care is an increasingly public debate. Just this week, there were some consequential hearings on pharmacy benefit managers and utilization management practice on Capitol Hill. And while cardiovascular disease enjoyed years of pretty good access of treatment, you can ask any clinician sitting on a panel today, and they will tell you what I also know is true. Access is a daily challenge and is getting ever more difficult. My team spends about 37 hours every week fighting for patients to get their therapy, behind the scenes, filling out forms, talking to an orthopedic doctor about a cardiovascular event. It just goes on and on. But these challenges do not mean we are losing the battle. They do not mean we should give up. They do not mean that we are making progress. We have witnessed in the last year what works, and that is collaboration. Represented today, we have many of our member groups. We have the American College of Cardiology, even the American Heart Association in this room. We have dozens of patients, providers, executive directors of influential health groups. And we know if we work together, we can achieve great outcomes in policy and treatment. It is amazing to see how far our organization has truly come. And I believe that we owe the majority of our success to our members and their willingness to come together to solve access problems for our patients. When we need a doctor in a specific state or a patient example in a specific disease state, we send out the call and our members always answer. And for that, we are grateful. We will continue our fight for patient-centered policies, and Patch looks forward to working with you all to achieve great policy outcomes. Together, we can do great things. I want to say thank you once again to the Patch team for getting this together, and thank you all for being here, because as a voice together, we can make that change. And so thank you very much.
Our first panel is Combating the Cholesterol Crisis. Please welcome our panelists, along with moderator Amanda Conshafter with Woodbury Associates.
Good morning. Welcome. I'm Amanda Conshafter. I'm a Senior Vice President at Woodbury Associates, which is a public affairs firm here in Washington, D.C., and I'm pleased to moderate today's first panel. So our topic this morning is high cholesterol, which we know afflicts about 40% of people in the United States, according to the CDC. Now, that's a startling statistic. It's also a dangerous one, because we know that high cholesterol is a driver of heart attack, stroke, and heart disease, which remains the #1 killer in this country. So this morning we'll explore what is truly a public health crisis, and we'll look at it through 3 very unique perspectives. I'm pleased to have with me today Lisa Mayer, who is a nurse practitioner and also president-elect for the Preventive Cardiovascular Nurses Association, Ryan Googe of the Partnership to Advance Cardiovascular Health, whom you just met, and also I'm pleased to have Darren Burnham, a patient advocate from Huntsville, Alabama, who has a personal story about the toll of high cholesterol. So thank you 3 for joining me this morning. So Darren, I'd like to start with you, if I may. So I just rattled off some statistics about the public health impact of high cholesterol, but I know that for you and for many people like you, high cholesterol is personal. And so I wonder if you might share with us a little bit about how you first discovered that you had high cholesterol and how that discovery really changed your life.
Well, growing up, I have family that had heart disease. It was common in my family growing up that someone was going to pass away with a heart attack. It was just what it was going on in our family at that time. So as I got older, my father started getting symptoms and signs, and he passed away at the age of 56. Then my mother passed away at the age of 63. Then my brother passed away at the age of 44, and my sister passed away at the age of 49. So it's just me and my baby sister that are still alive. It's something that we deal with on a daily basis. I've had 4 heart attacks, and recently, as of April of this year, I had a 5th heart event where I had a 99% blockage in my LAD, which is the lower or the left anterior descending artery, which they call the widowmaker. And then I had an 80% blockage in my right coronary. I have now currently 9 stents placed in my heart. So I didn't find out about the disease I have, which is familial hypercholesterolemia. It's a genetic disease that gives me high cholesterol. Normal cholesterol runs about around 100. My cholesterol runs in the LDL runs in the range of 400. So high cholesterol is considered 160. So I'm extremely high on the scale. I found out after my 4th heart attack that was what the disease was. So just a standard cholesterol panel did not bring up all of the genetic testing that is needed to identify my disease.
So you knew it was a risk, but you sort of solidified that after you had your heart attacks and
Correct.
spoke
Yes,
with your
ma'am.
doctor. Yeah. So Lisa, I'm curious to hear from you from a clinical perspective. You're working with patients like Darren on a daily basis. What are some of the trends that you see?
Yeah, well, a lot of the trends are, if we go back 50 years, look at that patient that presents with high lipids or heart attacks looked very different than what we are seeing now. So if you think back 50 years, the typical patient was obese, smoker, and white. Now we know that clinical picture looks a lot different. Younger, much younger. It's not uncommon for me to see people late teens, 20s, 30s, and we're having these same events, which is really scary. The other thing we've got to consider is our lifestyle, preventative, primary prevention. And we look at the things that we can do, that we can change: diet, exercise. We're not really doing a great job in those things, and those are the things that we can change. The other thing is skyrocketing rates of diabetes. So if we think, too, with heart disease, about 800,000 events are happening on a yearly basis. 30% of those are recurrent events. So not only are we not doing a great job with primary prevention, then we get into the other prevention areas, secondary and tertiary prevention. We're not doing great with those categories either.
Now, Ryan, at the Partnership to Advance Cardiovascular Health, you're working with patients like Darren and clinicians like Lisa. What are some of the specific obstacles that the organization is trying to address?
Well, I think there's one thing I can talk about that we're actually going to address today, and it gets to this statistic that Lisa just shared, that 30% of these events are recurrent, which is just incredibly high. And part of that, there was an article that was published in 2018 that said that post-event in a Medicare population, a study done of hundreds of thousands of patients, fewer than 10% had their LDL checked after the event. And within 3 months, it was like less than a third had their LDL checked after an event. And so what we actually did is spearhead a letter with a number of aging groups to address the Medicare population, then, of course, a number of cardiovascular groups to the Senate Aging Committee. and ask them why this is happening within the Medicare population. And so we're hoping that through our conversations that Dr. Patel and I are going up there today, we can encourage the committee to potentially hold a hearing on this. Maybe we have a report that comes out of this so that we can at least shine the light on these screening rates so that we can at least figure out, who has elevated cholesterol and then go treat it afterwards. The second thing is that, there's been a lot of innovation in this class, in cholesterol management, in particular around the PCSK9 inhibitors, the bempedoic acid, you name it. And the access challenge has been really high in the past. We think it's getting better, but we do know that from some recent data that we've looked at, that step therapy protocols can be complicated, and for the physician or the nurse practitioner who's trying to write a script to get their patient's cholesterol managed, it can be a real burden. And I know Lisa can talk more about that better than I can.
Well, let me ask this. Actually, Darren, I want to hear from you for a second. So Ryan describes, and we heard Dr. Patel talk about this during his opening remarks as well, it sounds as though it can seem pretty impossible or even be pretty impossible for a patient to actually get the medication that they need, the medication that they're prescribed. And I'm curious if that was the case for you as well.
Yeah, actually, after my third heart attack, my doctor prescribed a PCSK9 inhibitor, and it took me 8 months and an additional heart attack before I could get approved for that drug. Then my insurance company changed when I changed jobs. Then it took another month for the new insurance company to approve me for a second time. Then my company changed insurance to the insurance company that I previously had, and I was like, great, this should be no problem. They have already been approved. No, that was not the case. It took me another month to get approved a second time with the same insurance company for the same drug that I had originally been prescribed.
That's incredible. Can you tell us a little bit about what that was like? I mean, I imagine you were in touch with your doctor and his or her staff pretty regularly. I mean, this is a back and forth process. There's lots of paperwork.
Yeah, it's having to stay on the phone with the doctor, insurance company, the burden that it puts on the family, because for me, my cholesterol runs so high that if I don't have treatment, it can get out of hand, and I could end up having another heart event, which puts more of a burden on my family. My wife is phenomenal at getting the doctors and the insurance company to do the things that they need to do so that I can have the care that I need.
It's kind of like a part-time job.
Oh, absolutely. And my wife actually does that on a full-time basis for my health.
Lisa, I can't imagine how frustrating it must be for a clinician to see patients like Darren jumping through these hoops, jeopardizing their own health in the process. Are things getting any better for people who need PCSK9 inhibitors?
Yeah, they're definitely getting better, but we have a long ways to go. There's so many hurdles in place. And you hear Darren's story. This is a typical story I hear on an every single day basis. He's not alone. This is not just a one-off experience. So these are the instances that we're missing on a daily basis. And I will tell you, that is one of the most frustrating things in my job. I love my job. I love working with patients. I love when we can have good success stories. And Darren's lucky. He's lucky to have a supportive wife. He's lucky to have someone who has been willing to work for those access issues. But we still have a long, long ways to go.
Ryan, on the policy level, is the advocacy community seeing any progress?
Yes, I think so. I think that, around cholesterol management, when it comes to policy and advocacy, it's a success story to a certain extent. I can remember when, to take the PCSK9 example, when that class of medications came to market, 2016, I think it was, there was a patient that I met named Craig. He was from Florida. and this is a true story. Craig had 7 stents or 7 bypasses by age 50. He had total cholesterol of 840 at one point. He was on some medication, I can't remember what it was, but it was very, very expensive. And when the PCSK9 inhibitor came to market, he and his doctor were very excited about it because it was going to cost a lot less money, and it was going to be very effective, and it would be good for him. He had homozygous FH, so a very severe form of FH. They put in the prior authorization. It was denied. And he had to fight and fight and fight. And it was presumably going to actually save the plan money, which was I think the way he put it in one of the videos we did is that I was just baffled by that. Now, that was 2016. I don't think that we hear that stories like that anymore or that is severe. However, I will say that when we look at different plans in different states, it can be a little bit patchy in terms of access, and it sometimes doesn't make a lot of sense. You'll see, in particular, with certain states, what we look at is we'll look at prior authorizations and try to see, how many patients are getting put on therapy after the initial PA goes through. What we find is that if there's that initial denial, there can be a long wait period for them to actually get through the back and forth with the insurance company. And also there could be a lot of steps to get through. And you heard a little bit of that from Darren. There could be a lot of reasons for that. But it's interesting to me that you look like at a state like Louisiana or Mississippi that both have kind of a similar situation in terms of health plans. They have big health plans in those states that cover most of the citizens in that state. And both of them have kind of just very different numbers when it comes to access. That doesn't make a lot of sense. Mississippi and Louisiana both have high rates of cardiovascular disease, kind of similar, racial demographic makeup. Why you have this kind of disparate access landscape in those states, for instance, just as an example, doesn't make a lot of sense. So I think we've come a long way as a community when it comes to cholesterol management and access to care, but there's definitely more that can be done at this point.
Thinking a little bit about advocacy, Darren, I would be curious to hear from you. So I know that this weekend you participated in the Cardiovascular Leadership Academy, and I know we referenced that earlier. So this was a first-in-the-nation program that invites patients like Darren to come and to train so that then they can go home to their home states and communities and really advocate to drive policy change so that fewer patients have to deal with some of these struggles. Thinking about your experience, I'm curious if there is a single takeaway or piece of advice that you would offer to patient advocates like you who were trying to improve their own access, but also cardiovascular health and access on a broader scale.
Advocacy is extremely important. You have to be an advocate for yourself and those that don't have a voice. My family did not know until I was diagnosed with FH that there is a disease and a prevention for that disease or a help for that disease, but you don't have access to it immediately. So advocating is extremely important. We learned this weekend the difference in the supply chain of goods and the supply chain of money, which was helps us understand a whole lot more about why the things are put in place that block what we actually need. So advocating is extremely important. It gave me a better understanding of how to approach our politicians and our policymakers on how to speak to them to get those policies and those things changed. It was really informative on multiple fronts as far as how to advocate.
That's great. Lisa, I wonder if you might tell us, thinking again, sort of forward-looking, what is the single thing or a few things that you would really most like to see change to improve patient access moving forward?
I think we can kind of group that into 3 categories. So we can think of from a patient perspective, from a clinician or a provider perspective, and then from an overall healthcare perspective. So when we look at a patient perspective, we're going to look at how easily can you get what your clinician wants. Is it something that you experience hurdles? If so, what's going to be your compliance rate? The other thing I think is advocacy from a patient level. So the leadership training that they went through this weekend is an amazing thing. We need to offer more things like that and have patients educate other patients. I think information coming from a clinician to a patient is a lot different than information coming from patient to patient. Through someone who's actually experienced that disease, I think it's a lot easier. I can sit up and harp at my patients and tell them, this is what's good for you. Do they always listen to me? No, they don't. But I think that patient perspective, so patient to patient, it makes a huge difference. From a clinician standpoint, I think some of us are good at getting to the guideline-directed medical therapies, but there's a difference. I read one study where cholesterol management can vary by provider from being 28% following the guidelines up to 100%. Well, gosh, I sure hope nobody's seeing that patient or that provider that's only 28%, following the therapies. That's scary. So from a medical standpoint, we need to do better to educate ourselves and to continue to push those limits. I think that's hard because there is a healthcare shortage too. And so when I go to my nurse and say, hey, this is the medication I'm sending through, and she looks at me like, great, how many hours am I going to have to spend, refilling out the paperwork? And then it got denied, and I say, submit it again. Here we go. So, that puts strain on then our staff too. And then the third thing is healthcare system. I'm going to group this into a whole, that can be cost, that can be insurance, that can be pharmacy. There's a lot of work to do on each of those areas that we need to better improve.
Ryan, having worked with the participants of the Cardiovascular Leadership Academy this weekend, are you hopeful about the changes that lie ahead?
Oh, thrilled. I mean, as Dr. Patel said in his opening comments, it gives me so much joy to empower people. I mean, honestly, that's what I wanted to do with my entire career. And so there's nothing better, first of all, the energy that we get from the folks who joined us this weekend, who are passionate about helping others. I mean, that's just inspirational to me. And it's no small thing to put yourself out there, in front of a politician or an elected leader or in front of the media. It's a big deal. And the fact that we have folks that are willing to do that gives me all the hope in the world. And it makes me think that, look, if Patch and some of our member groups, I mean, I also want to say, Women Heart has an amazing leadership program as well. Some other groups do as well. We wanted to be kind of like a finishing school in a way with this Leadership Academy. How do we kind of add the policy element to this to patient advocacy? And if we can do that, I think that the sky's the limit. I mean, we have to remember that these folks on Capitol Hill or in state governments, they work for us, right? Sometimes it may not feel that way, but they do. And so if we can really give people the tools and the knowledge to go talk to them in a way that talk to them about their disease state and people like them, like Darren's story, I think that it can be incredibly impactful. And we've seen it happen. We'll talk about it some more later today.
Thank you. Well, we saved a few minutes here at the end for audience questions. So we have team members with microphones walking around the room. If you'll just raise your hand if you have a question. We also open it to members of the virtual audience as well. All right, so Elise, I think we have one back here.
A question for, is it working? No.
Yep.
Yeah.
Question for Darren. What is your cholesterol now from 400?
So I've actually experienced a greater improvement from my PCSK9 inhibitor than most people. My cholesterol went from a LDL from a 420-ish to now I'm at 146.
Wow. What about your HDL?
My HDL runs around 60.
Did it go up at all from?
It went up a little bit. I was like at 56, 57, and went up to 60.
Are you on a statin as well?
I am not, no. I do take Zetia, which is, I don't know what kind of drug it is, but it's not considered a statin.
Other questions?
Laura?
Yes.
Hi, good morning, everybody. Laura Saplavy. We talked a lot about access to drugs. Can you guys comment a little bit on access to cardiac rehabilitation and what that's like today's environment? Because you mentioned prevention strategies that are really maybe not being implemented. And I go back to like where it starts from after you have a heart attack. And are they learning the right tools to get out there and then think about preventative medicine?
We could have a whole panel on that,
That's
Laura.
a great question. Yeah.
So I think access to cardiac rehab is good if you have an event and then you can get access. So Darren, after each event, he can typically get coverage. Now, whether his plan will pay the full amount or charge a copay each visit, that's also to be determined. As far as diagnosis-wise, if you have someone who hasn't done cardiac rehab and you can get them covered under a chronic stable angina, I typically try to use that for my patients who don't have access to exercise equipment or to a safe place to exercise. The other thing is with heart failure, we're working on access from a heart failure standpoint and from a PAD standpoint. So I think that's, there's a lot of work yet to be done. It's not covered completely, and I think that's definitely an area we could push.
I'd like to speak to that as well. So every event that I've had access to cardiac rehab. One of the things that I thought was great about that program is you have someone that will be able to guide you in the exact type of exercises that you can do to build your heart back up. I've been blessed enough that in the 5 events that I've had, I attribute a lot to cardiac rehab is I have 0 heart muscle damage, which is amazing for anybody.
I think we have time for one more question. Over here in the corner, Dr. Patel. 1 second, he's bringing you a mic. There we go.
Darren, I just want to say you did a fantastic job as being a patient advocate. A question that's not talked about, the taboo question. You unfortunately have had many cardiac events, and I know access has been an issue. With all this going on, did you have any kind of underlying depression, anxiety, etc.?
For me, I didn't have a lot of pressure, but anxiety. But I'd like to speak to the effects on the family. My wife has extreme anxiety on me having another event. It's not just the patient that has the problems, it's also the family members, because there's a lot of people that, unlike me and my wife, that have access to therapies and things like that. They don't have those types of resources to be able to deal with this. My mother, for instance, when my father passed away, she had a lot of anxiety that she did not have access to resources to be able to help that. So not only the patient, but also the patient's family. Great question, Dr. Patel. Yes.
Yeah. Thank you for sharing. I think we're at time, so if you'll join me in thanking today's panelists.
Chances are someone you know has high blood pressure, because today, about half of Americans live with high blood pressure, also called hypertension. And for Black Americans, that number is even higher. Why? Black Americans have higher rates of risk factors like diabetes and high cholesterol. A lack of good health insurance or access to healthy food options can make matters worse. But you see, hypertension is dangerous. It can lead to heart attack, stroke, and heart disease. That's why we need solutions, and now. It's time for innovation, access, and awareness. Together, we can make hypertension history.
Hypertension is a common condition, but when it comes to managing high blood pressure, each patient's struggle can be different.
I know it's important to take my blood pressure medicine, but I just forget. I've tried everything. A days of the week pill box, reminders on my phone, taking my medicine at the same time every day, even asking my family members to send me text messages. I worry, because I know that missing doses can be dangerous.
A few weeks ago, my doctor told me I have high blood pressure. He said that because I already have diabetes, I'm at an even greater risk for heart and kidney disease. The doctor wrote me a prescription for blood pressure meds. The last thing I want is more pills I have to take. And why should I? I don't exactly feel any different. Sometimes I wonder if these pills even do anything.
My husband, Hank, has been working hard to get his blood pressure under control. He's done everything the doctor asked. He's eating healthier. He's exercising. He's taking his medication. But Hank's blood pressure doesn't seem to budge. He gets frustrated, and I can understand why.
The struggle to get high blood pressure under control is specific to each patient. So is the solution. That's why patients with hypertension need encouragement, innovation, and a personalized care plan that works for them. With the right tools and an individualized approach, patients can make hypertension history.
About half of American adults have high blood pressure or hypertension, increasing their risk of heart attack, stroke, kidney disease, and even death. But not all Americans are equally affected. The burden of hypertension falls disproportionately on communities of color. Compared to their white peers, Black Americans are 20% more likely to have hypertension, and they experience significantly higher rates of cardiovascular disease-related death. Hispanic Americans are more likely to go undiagnosed and more likely to experience kidney complications as a result of their hypertension. And Asian Americans face greater difficulty getting high blood pressure under control and experience more severe strokes. These disparities can stem from different factors, such as inadequate health insurance, lower income levels, lack of reliable transportation, less access to healthy foods, and language and cultural barriers. And the problem of hypertension just keeps growing. If things don't change, more than 25 million additional Americans will have hypertension by 2035. Now is the time for greater awareness, fresh approaches, and innovative solutions. The time for every patient, especially those disproportionately affected by hypertension, to have access to a treatment path that works. Now is the time to make hypertension history.
The program will resume in 5 minutes.
It can start with sores on the legs or feet that won't heal, pains in the calves, especially when walking, or pale, even blue-colored feet. These are the signs of PAD, or peripheral artery disease. PAD happens when arteries, usually in the legs, become narrow or blocked, and certain factors make people more prone to the disease than others. People who smoke or are overweight are more likely to develop PAD. So are people living with type 2 diabetes, high cholesterol, or high blood pressure. The likelihood of developing PAD is also higher among people who are over the age of 50, African American, or have a family history of the disease. And when it comes to PAD, the stakes are high. If left untreated, the disease can cause a heart attack or stroke. It can also lead to amputations. That's why screening is important for people experiencing PAD symptoms. For people who are diagnosed with PAD, it's equally important to develop a treatment plan with a healthcare provider. A plan to improve quality of life and slow disease progression might include maintaining a heart-healthy diet, managing conditions such as high blood pressure, diabetes, high cholesterol, or obesity, exercising regularly, taking prescribed medications to reduce the risk of heart attack or stroke, or practicing good foot and skin care to prevent infections. Through widespread screening and effective disease management, healthcare providers, patients, and policymakers can work together to reduce PAD's impact in communities across the country. Learn more at advancedcardiohealth.org.
Non-medical switching essentially undermines what I went to medical school for. Our patients who have chronic conditions, they are extremely difficult to treat because we're juggling different disease states. You end up using 2 to 3 pills for hypertension. You end up using 2 to 3 pills for diabetes. You end up using 2 to 3 pills for heart failure. You could end up using 9 to 12 medicines when we have finally got to a therapy that works. And then we get the phone call that the medicine has been changed. That's the ultimate nightmare for the physician. Non-medical switching is when insurance companies enforce switching therapies for financial gain. Unfortunately, we have had victims of patients due to non-medical switching. Patients who are on good blood pressure medicines which were working great. They were switched and the blood pressure spiked and they went on to have a stroke. I would like to be involved with healthcare plans when they decide about which patients of mine get non-medical switching. Patients, they are my extended family. And with that, they do bring an element of trust. Non-medical switching is for populations predominantly, but we're not treating populations. We're treating patients one at a time.
Ladies and gentlemen, please take your seats. The program is about to resume. Our second panel is Making Hypertension History. Please turn your attention to the monitors for a special message from former U.S. Surgeon General Jerome Adams.
Hello, everyone. I'm Dr. Jerome Adams, former United States Surgeon General, and I hope you're all enjoying today's Cardiovascular Health Policy Summit. The next panel will discuss one of the most pervasive and troubling health issues in our country, hypertension. Hypertension is a complex disease, one that affects nearly half of all adults in our country, and hypertension can take a serious toll on patients. Today, only 1 in 4 people with hypertension actually has it under control. As many of you know, uncontrolled hypertension can have serious consequences. It can jeopardize one's health, including the ability to be physically active and mentally fit. And hypertension significantly raises the risk for serious complications like heart attacks, stroke, and kidney failure. That's why during my tenure as Surgeon General, I pushed to make hypertension control a national public health priority. In our call to action that we put together with partners, we advocated for a bold, coordinated, multifaceted response to address our country's hypertension problem. Our call to action encouraged that we do at least 3 key things. Number 1, we must optimize patient care for hypertension control, leaning on best practices. Number 2, we must ensure that places where people live, learn, work, play, and pray support hypertension control. And number 3, we must recognize the need for health equity, including interventions that are tailored, replicated, and scaled to encourage hypertension control across all populations. I want to commend the Partnership to Advance Cardiovascular Health for taking up our call and committing to raising the profile of hypertension and the need for evidence-based and personalized interventions. We can no longer be satisfied with incremental progress. With today's discussion, I invite you to consider how we can all come together to address this national challenge once and for all. I want everyone, doctors, nurses, patients, caregivers, business owners, and policymakers to understand we all have a role to play in making hypertension history. So thank you for your time, your dedication, and your commitment to this important mission.
Hypertension is a common condition, but when it comes to managing high blood pressure, each patient's struggle can be different.
I know it's important to take my blood pressure medicine, but just forget. I've tried everything. A days of the week pill box, reminders on my phone, taking my medicine at the same time every day, even asking my family members to send me text messages. I worry, because I know that missing doses can be dangerous.
A few weeks ago, my doctor told me I have high blood pressure. He said that because I already have diabetes, I'm at an even greater risk for heart and kidney disease. The doctor wrote me a prescription for blood pressure meds. The last thing I want is more pills I have to take. And why should I? I don't exactly feel any different. Sometimes I wonder if these pills even do anything.
My husband, Hank, has been working hard to get his blood pressure under control. He's done everything the doctor asked. He's eating healthier. He's exercising. He's taking his medication. But Hank's blood pressure doesn't seem to budge. He gets frustrated, and I can understand why.
The struggle to get high blood pressure under control is specific to each patient. So is the solution. That's why patients with hypertension need encouragement, innovation, and a personalized care plan that works for them. With the right tools and an individualized approach, patients can make hypertension history.
It's me again. I'm up here again, y'all. Great to be here. Ryan Googe again with the Partnership to Advance Cardiovascular Health. And this panel is about making hypertension history, which may be the best tagline that we've come up with. I love that tagline. Grateful for our communications folks who came up with that. So as former Surgeon General Adams said in his introduction, hypertension is without question one of the country's most pervasive and troubling health conditions. And that fact really can't be overstated. If you think about it, more than 500,000 Americans die each year as a direct result of hypertension. And from a cost perspective, it costs more than $130 billion each year in direct health care costs, including emergency room visits and hospitalizations. Now, We know that the burden of hypertension, as I'm sure many of you are aware in this room, is immense today. But if you look at the future tomorrow, it will be even greater. By 2035, it's estimated that 25 million more adults are expected to develop hypertension. And so here at Patch, what we think is particularly needed is bold policy to address treatment management and non-adherence. So today's panel, we're going to bring together all stakeholders, as we try to on all of our panels and everything that we do, patients, clinicians, advocates, to paint a picture for just how burdensome hypertension is and discuss some approaches that we can take to make hypertension history. So joining me today is the man of the hour, Dr. Dharmesh Patel, a practicing cardiologist at the Stern Cardiovascular Foundation in South Haven, Mississippi, an expert in hypertension. He also serves on the Southeast Board of the National Lipid Association and on the board of the American Society for Preventive Cardiology. Also, we have Anyakin Ebitu. Anyakin is the National Senior Director of Public Health Programs at the National Hypertension Control Initiative at the American Heart Association. She has more than 13 years of experience working and analyzing public health-related programs within governmental and non-governmental organizations, local health departments, and academic institutions to ensure the delivery of strategic operational support toward healthcare development initiatives. And finally, last but not least, we have Paul Griffin from Newnan, Georgia. Paul has the best job. He's retired.
Yes.
And he is an advocate and with us today to share his journey about his hard-to-control hypertension. So as you saw from Dr. Adams, who introduced the panel topic, and then that video, which is that you all are the first to see that video. It's one of my favorite that we've put out today. Hypertension can be a real struggle for patients, and everybody's journey is different. So Paul, as the patient, I would love to hear about your journey. If you can share with us what your heart history has been and your struggle with hypertension. We'd love to hear it.
I was first diagnosed with hypertension, high blood pressure, 20-something years ago. At that point, I was in my 40s, and I didn't need to go to the doctor, but suddenly I found out I had high blood pressure. The doctor, of course, put me on a pill, a medication, and for a while, that one pill seemed to control my blood pressure. I remember the doctor telling me, though, is when he put me on that first medication, was that high blood pressure is the silent killer. As we've heard this morning, you don't always even know you've got it. And I did fine for a while. I did have the privilege of going to see the doctor more often. And that one pill worked. Shortly after that, though, I developed a dry hacking cough. And it persisted a long time. Finally, it was determined that I was having a reaction to that particular high blood pressure medicine. So on another doctor visit, my medication was changed. Shortly after that, maybe a year, I started developing an irregular heartbeat. I was having PVCs, irregularity regularly, and the cardiologist I saw decided we needed to do a full cardiac workup, including a heart cath, which everything was fine. And there was no real way to know that if the hypertension, the high blood pressure had caused that, but it was certainly in the realm of possibility. As I continued to age, my blood pressure continued to rise. And as my blood pressure continued to rise, so did the number of medications I was taking. To where I finally got to the point that with 4 high blood pressure meds, I was controlling my pressure only down to about 145/95.
So, Dr. Patel, I'm curious, as someone who sees dozens and dozens and dozens of patients with hypertension, what about Paul's story resonates with you and you hear a lot? And then can you also, well, let's start with that. What do you hear in your office? Is that story typical? Can you provide some more context to some of the patients that you see?
Yes, I think Paul's story is very poignant. Remember, the average American takes about 3.5 blood pressure medicines to control blood pressure. I'll go as far as saying 50% of the patients here, or the people here, have high blood pressure. But to Paul's point, most of my patients don't feel bad, right? Remember, you're just hearing about the 5% who have high headaches, don't feel good. 95% of us don't feel nothing. And just like I've said before, when people have a heart attack, 40% feel great the day before they die. So the sad thing about hypertension is, as you have said, you know, by treating Paul's blood pressure, you reduce the risk of having heart failure 50%. You reduce the risk of having a stroke by 30%. You reduce the risk of having an MI by 25%. But he is typical patient USA. Doesn't feel bad, needs a few medicines. And unfortunately, Paul, our dilemma with patients is, of course, every patient's different, and certain medicines agree with certain people and some don't. So we're always fighting to get the right concoction. And I'll say the last thing. Most people like Paul will stop taking their blood pressure medicines. Up to 50% will stop taking their blood pressure medicines after 1 year. So adherence is important. You know, we don't keep taking the medicines, just like the cholesterol story. We don't continue to take our medicines.
Do you think, Dr. Patel, when you talk to patients that they understand, if you give them a diagnosis of hypertension, that they understand like what the risk really is?
In simplistic terms, absolutely not. Because there's no voice for hypertension. Where is the voice for hypertension? If you have a broken arm or you have heart failure, there's a voice. You've got a pain in your arm or you're short of breath. Where is the voice for hypertension? There it is. There isn't one. And so our point being that we need to further educate patient populations, as was said by the general surgeon, go to churches, go to town hall meetings, go to different prayer rooms, wherever it has to be. But let's get the message out. Know your numbers. Get the blood pressure down.
So before I let you go and move on, talk to us a little more about adherence and that issue for your patient population. I mean, how...
Yeah, I mean, adherences are the biggest crux of every disease state we're going to talk about today. Cholesterol, 50% stop, statins at 1 year. Hypertension, 50% stop at 1 year. And remember, it's not just simply adherence. Well, Dr. Patel gave me a medicine. Now he wants to give me another medicine and another medicine. Does he truly know what he's doing? In fact, I've lost faith in him. Mm-hmm. But the unfortunate thing is most patients need 2 to 4 medicines to treat hypertension. As was said earlier today, we're losing the fight against cardiovascular disease. Our population is getting more inactive, more obese. Diabetes is doubling every 10 years. If we don't beat this epidemic, we will go bankrupt as a country.
So, Ani Aiken, I think it was last week, maybe the week before, Patch hosted a webinar with the Congressional Black Caucus Institute. And on that webinar, it was a fantastic discussion. We had Congresswoman Joyce Beatty, who's the co-chair of the Heart and Stroke Coalition in the U.S. House. We had Dr. Barbara Hutchinson, who's president of the Association of Black Cardiologists. And we had Pamela Garman-Johnson with the American Heart Association, your colleague. And on that webinar, we actually talked about the state of hypertension in Black America. Correct. And it was a fascinating discussion. In fact, Congresswoman Beatty committed to introducing some legislation around blood pressure monitoring, which we're really excited about, and we're going to continue to talk to her about that. But one thing that we did not get to do on that webinar, because it was just such a riveting conversation, is talk about the National Hypertension Control Initiative at the AHA. And so I wanted to give you the opportunity to talk about what AHA is doing with the National Hypertension Control Initiative.
Sure, thank you for that question. The National Hypertension Control Initiative is a demonstration project. It's being funded through the Office of Minority Health and also the Health Resources and Services Administration. We all sit under the bucket of the U.S. Department of Health and Human Services. It's a 3-year project. We are focused on priority population, and that includes Black, Hispanic, Native American, and also Alaskan Native. I think when we started this work, it was during COVID, and we saw the impact that COVID has also had on people's high blood pressure, hypertension, et cetera. When we started this work, we were at a control rate at 52.6%. Currently, right now, we're at 55%. The goal by the end of this project is to get the control rate at 80%. We are working with federally qualified health centers. If you know federally qualified health centers, or we also call it community health centers, we have roughly 1,400 across the United States and also U.S. territories. We are focused at the AHA 350 of those health centers. The government funded 496 health centers to address high blood pressure, hypertension. The AHA were provided with 350 health centers. We did not select them. They were selected for us by the federal government. So that's where the data came from, is the control rate across the 350 health centers was at 52.6%. I think what makes our project unique is we're not only focused on addressing hypertension, providing training, technical assistance, etc. We're also going to the communities as well. We are funding community-based organizations. We're funding different entities to empower patients to take control of their blood pressure.
So a couple follow-up questions. First of all, on the webinar last week or the week before, we were talking about the state of hypertension in Black America and really the disparity in treatment and outcome for Black Americans when it comes to hypertension. So I was hoping that you could maybe put a finer point on that for us and help the audience understand how acute that is in Black American population.
Definitely. I think a lot of times we see patients going to their doctors when something is wrong. And I think we always have to uplift the importance of people going to their routine checkup as regularly as possible. I'll give a personal story. I have a cousin that recently just passed away last week. Didn't go to the doctor, but he knew he may have had like high blood pressure, hypertension. And he was just taking his medication once in a while. And he was only 39. And he literally went to drop his daughter off in school, came back, and he just slumped, and that was it. So we try to advocate and tell people, you have to go into your doctor, just do your routine checkup, follow your doctor's appointment. In addition to that, as Dr. Patel just mentioned, people are not educated enough. Do they actually understand that they have high blood pressure? Do they actually understand what that means? So we find ourselves working closely with the community-based organization because they live there. They work with the communities. We're funding an organization called Black Nurses Rock because they focus on African Americans, and they want to uplift the importance of people checking their blood pressure at home before going to a doctor. So it's very difficult, but all you can continue to do is to advocate for them and share that information about, do you actually have a provider, or can we help you find one within a community health center within your area?
So you mentioned the Black Nurses Rock. I was curious if there's another organization that you'd like to point out that you're really excited about what they're doing.
Absolutely. So we also have the Links Foundation and also Jack and Jill of America. We're also funding a CBO based here, a community-based organization based here called the Central Maryland AHEC. We're also funding Florida State University, and I'm missing one. Stanwell Mary University in California. But I think I'll focus on the Links Foundation because they also work with mothers and children. A lot of women have high blood pressure or a risk of high blood pressure when they are pregnant. But I think the main thing that they're focused on is, do you actually have a blood pressure device? I think during the webinar last week, one of the doctors had mentioned that a patient was not provided with a blood pressure machine until they had a stroke. Do we have to wait till a patient has a stroke or a heart attack before we provide them with a blood pressure machine? So with the Links Foundation, they are giving 300 patients blood pressure machines to monitor their blood pressure at home. And if they have a provider, share that information with their providers when they visit.
Fantastic. Dr. Patel, you touched on this a little bit, but I was hoping that you could kind of paint a picture for us what hard to control hypertension looks like and what patients can do to ensure that they're on top of their treatment regimen.
So to me, hard to control blood pressure is the same term as resistant hypertension, which is when someone cannot control their blood pressure on 3 blood pressure medicines, of which one is a water pill or a diuretic. That's about 12 to 20% of the population, and as mentioned before, as our population ages, it becomes more and more difficult for providers to keep up with controlling their blood pressure. Now, I want to step back and understand that other things do cause high blood pressure. One that we never talk is sleep apnea. That's when, of course, people sleep at night, they block their airway, they're drowning all night, they wake up, they feel like crap, have headaches. Well, that's the best way to say it. And,
medical term.
I mean, just got to lighten the mood a bit here. So that, I just say all this and they say, yes, yes, yes. You wake up, you didn't feel like you slept. Yes, well, you have sleep apnea, obesity, diabetes, etc. All these disease states that we forget about cause high blood pressure. So those need to be addressed first. But as mentioned today, thankfully there are, other innovations coming to help these harder to treat patients. Because remember, it may be that they cannot tolerate the medicine. Like you mentioned, you had a cough. There are certain blood pressure medicines that make a cough worse or cause a dry hacking cough. So every patient's unique, and we're trying to adjust therapies to get them to go.
So, Anyakin, AHA has a really great guide about devices to help control hypertension. So I was hoping that you could speak a little bit about innovation and technology and how they're, a driver in gaining hypertension control.
So I can definitely share this in terms of us partnering with the American Medical Association. I know the AHA is focused on research and training and technical assistance, but something we found from the health centers is blood pressure machines integrated into their EHR, the electronic health record, the electronic medical records. Something that we've worked on is something called validatedbp.org. So pretty much these are blood pressure machines that would integrate better or integrate into a EHR system. That way, if a patient is checking their blood pressure at home, it can actually, the provider can see that on their end, or they can get a copy of that reading. So we've partnered with the American Medical Association. Something we're also working on is receiving this feedback from the health center, the challenges that they're having. So we're partnering with a company called Unity Health. Unity Health, he provides training and technical assistance on integration, data security, et cetera, to our health centers. And we provide that to the health centers for free. But he's certified in 5 different EHR systems, so we try to make sure that whatever he's providing to the health center, they can integrate with their clinicians and their staff member. I think something I also wanted to uplift is we call it the social navigation platform. I'm not sure how many of you are familiar with Find Help or Unite Us, but we talk about patient engagement, helping patients, but truly we want to meet patients where they are, and sometimes we do try to address patients' social needs. So with the social navigation platform, if a patient is telling you they're about to lose their apartment, they don't have housing, they need senior housing, can we actually provide them with tools and resources? So for example, with Find Help, if you were to go on their website, you can put in your zip code, and it will tell you the closest area for you to get housing assistance, transportation, senior housing, food, etc. So I think it's very important that as much as we want to uplift the importance on high blood pressure, hypertension, patients care about their health, but if they're about to lose their apartment and stuff, their focus is, I need to figure out where I'm going to live the next day. So we use those technology platforms to uplift meeting patients where they are.
Dr. Patel, we may hear about this today when you and I are on the Hill later, and we may hear about it a little bit tomorrow, but there's actually legislation running right now through the process of HR 1691. It's the Ensuring Patient Access to Critical Breakthrough Products Act, and from what I understand, what it's trying to do is clear pathways for breakthrough medical devices so that there's no delay when these things come to market for Medicare patients, for instance. So for me, that signals to me that Congress or our policymakers see the need for innovation in this space and making sure that people get access to things. So I'm curious from the clinician perspective, are you and your colleagues thinking about new things that can be done for this, and do you see the need for innovation in this space, and are you all kind of clamoring for that?
Yes, I mean, let's talk about hypertension. We've been giving, quote, pills our whole lives. There's a potential of having a new innovative device therapy which would essentially kill the nerves around the kidneys, which will essentially reduce sympathetic drive and reduce blood pressure. So to us, this is a huge breakthrough. It'll be the first breakthrough in hypertension for, 30, 40, 50 years. So the point I'm trying to make is when it does come out, hopefully it will, as clinicians, we want to help patients like this man here, who took 4 medicines. It wasn't to goal. He wasn't very happy about it, understandably. And, we need tools that can help us. We want there to be less barriers for us. We want less prior authorizations. We want less step therapies. Respectfully, I understand what medicines or therapies I need to give to patients. And, after 20 years of doing this, I don't need to be told respectfully, I need to do this, and this. I know what's going to work and what isn't. Mm-hmm. And it's frustrating, but we want what's best for the patient always. And so I feel like with these new innovations, I'm really excited that hopefully we can have breakthroughs, and or more importantly, when these breakthroughs come, we have access to them.
Mm-hmm. So Paul, to round us out here, we've had, you've heard from some of the patients that went through our training yesterday. I'm curious, as someone who's dealt with hypertension for 20 years, what is your message to folks out there who are dealing with hypertension today, and what would you tell them in terms of, making sure that they get it down?
I remember what the doctor told me 20 years ago, that it's a silent killer. Dr. Patel said the same thing. If you've got hypertension, stick with it. Take your medications, go see your doctor. Only through that will you control it. And there's, as Dr. Patel's just addressed, there's always innovations coming out to improve treatment for high blood pressure.
Great.
I'll keep it simple. If it tastes good, spit it out.
Well, with that, we got about. Always making it. We're gonna yodel for the balcony. We're gonna spit. Who knows what's going? We're off the rails at this point. Any questions from the audience? We have just a couple minutes here. Well, I would say, I want to say on our hypertension initiative that we've taken up this year. Obviously, there are a number of tools from the AHA, and Ani Aiken I'm sure, will make herself available to anyone that wants to learn more about those things and can connect with you. Because, as we've said today, throughout all these panels, collaboration is what's going to make the difference with all of these things, as the National Hypertension Control Initiative has made clear too, and is a priority for them. But also, I will say the video that you just saw, a number of materials that we've put out with Patch, I think can be very helpful in terms of raising awareness. And if you have, an hour over lunch, not today, but another day, to watch our webinar on hypertension in Black America, I would really encourage you to do that. It was really an incredible discussion, and we're really grateful for Pamela Garman-Johnson for joining us for that. But, it's just amazing to see someone like Congresswoman Joyce Beatty feel so passionately about it.
Yes.
And it gives me encouragement for the future.
Definitely. And I'll also add that I think he just mentioned, taking your medication. I also say advocacy, right? Sometimes we wait to the last minute. I think it's important that if you don't have a provider, community health centers are available. Just if you go on the HRSA.gov website, put in your zip code, it will tell you the closest health centers. They don't turn away patients. They have a sliding fee scale based on individuals' income. I don't want people, especially men tend to wait to the last minute. We've seen the research on Black men's health, waiting till something is wrong before going to the doctor. I shared about my cousin. He was so young, and it just happened last week. I'm like, wow. So truly, talking to your provider, talking to community members. I think something else that I would also add is people are now including blood pressure machines in barbershops and beauty shops to encourage patients, while they're cutting their hair, while they, we talk about our business and when we're getting our hair done, when we're cutting our hair. So just why not include a blood pressure machine and just asking your client, do you want to check your blood pressure? Do you know your numbers? And if it's high or elevated, going to a provider. So I think it's very important that we educate our community and share that information as much as we can.
Thank you. Well, with that, I'll say we work together. I think that we can make hypertension history, everybody. Thank you.
Feeling short of breath or fatigued from handling daily tasks. Swelling in the legs, ankles, or feet. Persistent coughing or wheezing. These can be symptoms of heart failure. Heart failure occurs when the heart cannot do its most basic job, pump blood and oxygen throughout the body. There are two main types. When the heart muscles are weak and cannot pump enough blood to circulate, that's called systolic heart failure. But when the heart muscles are stiff and cannot fill up with enough blood, that's called diastolic heart failure. Today, over 6 million Americans, men and women, live with heart failure. The disease is linked to high blood pressure, coronary artery disease, diabetes, and obesity. And people are more prone to heart failure if they are 65 or older, African American, or have a family history of the disease. If left untreated, heart failure can be deadly, but there are proven strategies and treatments to reduce symptoms and improve quality of life. So watch for the warning signs. Stay physically active. Maintain a heart-healthy diet. Take medications as prescribed. And visit your healthcare professional regularly to get the treatment you need to live a longer, healthier life. Learn more at advancedcardiohealth.org.
Hi, I'm calling from your insurance company.
It looks like your heart medicine will no longer be covered by your plan, so we'll have to switch you to a different drug. It's standard procedure. No big deal.
My heart medicine gives me peace of mind so I can sleep at night. No big deal.
My heart medicine keeps me from having a heart attack like my dad, my mom, and my great aunt did. No big deal.
My heart medicine's the only drug that didn't give me awful side effects. No big deal.
My heart medicine prevents me from having a pulmonary embolism. Again, no big deal.
My heart medicine keeps me from suffering a stroke during my daughter's piano recital. No big deal.
My heart medicine took 6 months, 3 drugs, and 5 doctor's visits to get right. No big deal.
When your health plan switches your heart medicine, it is a big deal. Learn more and share your story at advancedcardiohealth.org/no-big-deal.
The program will resume in 5 minutes.
Chances are someone you know has high blood pressure, because today, about half of Americans live with high blood pressure, also called hypertension. And for Black Americans, that number is even higher. Why? Black Americans have higher rates of risk factors like diabetes and high cholesterol. A lack of good health insurance or access to healthy food options can make matters worse. But you see, hypertension is dangerous. It can lead to heart attack, stroke, and heart disease. That's why we need solutions, and now. It's time for innovation, access, and awareness. Together, we can make hypertension history.
Hypertension is a common condition, but when it comes to managing high blood pressure, each patient's struggle can be different.
I know it's important to take my blood pressure medicine, but just forget. I've tried everything. A days of the week pill box, reminders on my phone, taking my medicine at the same time every day, even asking my family members to send me text messages. I worry, because I know that missing doses can be dangerous.
A few weeks ago, my doctor told me I have high blood pressure. He said that because I already have diabetes, I'm at an even greater risk for heart and kidney disease. The doctor wrote me a prescription for blood pressure meds. The last thing I want is more pills I have to take. And why should I? I don't exactly feel any different. Sometimes I wonder if these pills even do anything.
My husband, Hank, has been working hard to get his blood pressure under control. He's done everything the doctor asked. He's eating healthier. He's exercising. He's taking his medication. But Hank's blood pressure doesn't seem to budge. He gets frustrated, and I can understand why.
The struggle to get high blood pressure under control is specific to each patient. So is the solution. That's why patients with hypertension need encouragement, innovation, and a personalized care plan that works for them. With the right tools and an individualized approach, patients can make hypertension history.
Ladies and gentlemen, please take your seats. The program is about to resume. Our third panel is Left Out: Formulary Exclusions, Non-Medical Switching, and Utilization Management. Please welcome our panelists along with patient advocate and moderator Beth Waldron.
Well, thank you very much. As most of you know by now, I am a cardiovascular patient who experienced a non-medical switch in 2021. My doctor and I had made very thoughtful, informed treatment decisions about how to manage my condition, which places me at high risk for developing blood clots. So when the nation's largest pharmacy benefit manager removed from formulary the medication that I rely upon, not for clinical reasons, but strictly for a business decision, I was outraged. I had been stable on this medication for years. Here I was, a stable patient, experiencing no side effects, on a medication my doctor prescribed to treat a life-threatening condition. I had always advocated for my health, but then I felt the need to elevate my voice to advocate for other people who were also experiencing this unfair practice of non-medical switching. So today, we are bringing together a panel of experts to help us understand exactly what non-medical switching is, why it's happening, and what we can do to ensure that stable patients like myself can remain on their clinician-prescribed medications. So joining me today is Dr. Richard Kovacs, the QE and Sally Russell Professor of Cardiology at the Indiana University School of Medicine. Dr. Kovacs is a clinical cardiologist and served as the service line leader of cardiology for Indiana University Health Physicians from 2017 to 2022. He was responsible for the coordination of patient care activities across all 7 hospitals served by the Indiana University faculty cardiologists. He now practices and teaches at the Indiana University School of Medicine. And Dr. Kovacs also serves as the Chief Medical Officer for the American College of Cardiology, a position he started in November 2021. And next we have Kathy Oob. Kathy is the CEO of Pontchartrain Cancer Center. Kathy is a board member of the Community Oncology Alliance, chairs the Biosimilars Committee, and serves on their Government Affairs Committee. Kathy has a very deep understanding of the pharmaceutical supply chain and why formularies are putting profits over patients. And next up, we have Sarah Gilbert, who serves as U.S. Congressman and Dr. Neil Dunn's Deputy Chief of Staff and Legislative Director. Congressman Dunn is passionate about open access to treatments and patients having the right medications at the right time. So thank you all very much for being here today, and we've got a lot to discuss, so I'm just going to go ahead and jump right into it. Let's jump into it, Kathy. With you, I know I can't be the only patient that this is happening to. Patients across the country are showing up at the pharmacy counter, and what they're walking away with is not necessarily the medication that they had been on previously to control their cardiovascular issues. Can you please help me understand, why is this happening?
It's a cost-cutting measure on behalf of the insurer, and it's not just limited to cardiology. It's every specialty, including cancer, that we see this. Also, a lot in antibiotics. It's just truly this substitution on the side of the pharmacist. The health plan is deciding what they deem kind of that largest margin for them, and they can switch that as long as it's not for a clinical purpose. So they can do it for a business decision, and that can happen every time you fill your 30-day prescription for a drug. Those pills might look different every single time. Now, that might sound good, and it's really it's a business decision. But it is truly inserting itself in between the physician and the patient. And you brought up something very, very poignant and very real. You decide on a medication. It might take you weeks or months to land on that appropriate medication to treat your chronic illness. And then a substitution occurs. They are chemically a little different. There might be a certain additive or a dye in a medication, and you might react differently. So then we have that non-medical switch. It's interfering with the doctor-patient relationship, and then what else could happen? You might have side effects from it. new side effects. You might end up going to the doctor again because of that. So now you're having additional copays. You know, God forbid, but we see this as, you know, physicians on a Friday night at 3:30, you know, you get the phone call, well, you need to go to the ER. So then we're having all of these, you know, bubble ups, these side effects from these medical, you know, these decision makings, this formulary. And what they, you know, the health insurers are so focused on the cost of the drug that they've lost sight in what we call the total cost of care. So it's additional copays, you know, ED visits, maybe hospitalizations. You know, the caregiver can be involved in this mix too. So then we're talking transportation, but it's so focused on the drug that they're losing sight of care on all the other pieces.
I mean, what you're describing is really complex, and I know it's difficult for patients to understand, but I know it's also difficult, Dr. Kovacs, for clinicians to understand as well. And so, as you have, you know, have you seen this side of medicine change over the years? Do you, since you began practicing, do you think that we're having more challenges with insurers or payers, or can you just explain that to us?
Well, I've been at this for a long time, and I think in the old days it was very simple. You wrote a prescription, and either you signed on the left side, dispense as written, or you signed on the right side that generic substitution was allowed. That was a fairly simple thing, but what we're discussing now is much more complicated. So now you're in an electronic medical record with the patient in front of you, and you will prescribe a medication based on that patient's need. Then you hit the send button, and what happens after that send button is a lot more complicated. So you don't know if when the patient arrives at the pharmacy, if they're going to obtain the prescribed medication. Now, cardiovascular disease especially is very, very time sensitive. So there are medications that we prescribe, say, after a stenting procedure, that a day or 2 days delay while there is an appeal being made or while this dust is settling can make a difference. A stent can thrombose. A patient could die. A third of abrupt stent thrombosis results in a fatality, and the majority of the stent thromboses are due to interruption in the therapy. So these have real consequences, a heart failure or admission or an arrhythmic event. And we hear, okay, you can appeal this and we'll allow it on appeal and just fill out this form or whatever. So that is time consuming. We haven't totaled it up like Dr. Patel's practice in terms of hours, but I know that I have two medical professionals in our practice who spend their full time to doing this. That time spent doing this is time not spent with patients doing other important patient care activities. And then finally, the patient is wrapped up in this as well, and I wanted to raise the disparity that can exist, because it's one thing a tech-savvy, very medically knowledgeable patient can be their own advocate and help us navigate through this. But what about our patients who are less tech-savvy? We increase the disparities in care, I believe, by this practice, and I want to raise the third issue with disparities, and we haven't talked much about rurality, about our rural patients in areas where we know now there are disparities in care, and I believe that in the state of Indiana, my rural patients have a harder time with this than some of my urban patients.
That's interesting that you mentioned, you know, that you have delays in cares that contribute to the health outcomes, but then you also have this layer of health disparities that also exacerbates and leads to worse outcomes, and it sort of compounds itself. So, you know, it comes to the question of what can we do about this? And I know Sarah, Congressman Dunn, is very passionate about patient access issues because he is also a physician. And can you tell me more about his work and what he's doing to ensure that patients do receive the optimal care?
Yeah, certainly. Thank you. So I think, for background, Dr. Dunn ran a large single specialty urology practice when he was still practicing. I think one thing that keeps him up at night is the trend towards physician offices being owned by various entities. Physicians are being bought up by hospitals, PE, and I think most concerningly, the insurance companies these days. So that is just a concerning trend to see, and I think when we think about how to address that, I think we need fee schedule reform, macro reform, the ability for physicians to engage in value-based payments so that there is an incentive to remain independent. Unfortunately, the trend is it's so stark, 75% or more physicians are owned now, a trend that was accelerated by the pandemic. I think on a practical policy level, bills such as the Safe Step Act, which advanced out of the Senate Health Committee, as well as the Ensuring Seniors Timely Access to Care Act, which the boss was able to support when it advanced out of ENC last year, both address step therapy and prior authorization in the private market and in Medicare Advantage, are important policies to continue to pursue. And I think Congress is showing the administration that our constituents care about this, and the administration is taking steps on their own to kind of further these goals. So it's a great area of bipartisan agreement. I should also mention that the boss is the co-chair of the Healthcare Innovation Caucus. So this caucus really looks at, one, the amazing things that our innovators are doing to bring cures and treatments to market, but also how are we going to have tenable payment systems so that doctors can utilize these treatments and know that their patients will have coverage for them, won't be stuck out of pocket. That kind of goes to the point of the bill Paul mentioned also earlier regarding ensuring coverage for breakthrough therapies and ensuring that there are incentives there for doctors to increase uptake of the newest, the best for our patients.
It's interesting. We have these new policy initiatives coming about in part because constituents, the patients, bring them to you and they share their stories and say, this is what's happening to me. And, Kathy, one of the things that's driving these stories is we have a dramatic increase of formulary exclusions. Mm-hmm. And I think there was a 2022 report by AmerisourceBergen that showed that there's been a 300% jump in recent years. And that's just astounding to me. So, of course, you're going to have more patients being impacted and more patients sharing their stories. If I, as a patient, I feel like I'm paying more and more every year for health insurance. Mm-hmm. But yet formulary exclusion list continues to grow every year. Mm-hmm. So why is that? Why do we have that disconnect?
Well, we talked about this yesterday in the leadership training. So we have a cookie jar. Healthcare is a cookie jar. And 10 years ago, 15 years ago, there were a couple of hands in that cookie jar. The insurer, pharma, a couple of other people. And then now there's a lot more hands in that cookie jar. And especially PBMs. We cannot go out of this without talking about PBMs. But we have a lot more hands in that jar. Mm-hmm. And a lot of those, hands want a piece of that overall cost of care. And so they're extracting rebates, they're extracting dollars instead of lowering healthcare costs, which is what they purport to do. It's raising healthcare costs. And so, the insurers are doing formulary management for a few reasons. In oncology, the pipeline has exploded over the last 10 or 15 years. Mm-hmm. And so we have amazing therapies now that we didn't have available 10 years ago, but those are costly. And so, healthcare costs have risen because of PBMs, specialty pharmacy, vertical integration, lack of competition, but also, technology and where we are in innovation. And all of that has to be paid for somehow. But we talk about pharmaceutical manufacturers, we talk about PBMs. We're not talking about the insurer enough. Because I'm looking at all of you in the room and I own my business. When's the last time your premiums went down or your deductibles went down? They don't, but your cost shares continue to go up. And now we have formulary exclusions. And so you're paying more than you did 5 years ago. Your cost share is higher, and you might not even have access to the medications that you need. One of the bigger trends that we're seeing now in oncology, and I don't know about cardiology yet, but beware, is specialty medication carve-outs. They're just simply not on the insurer's plan anymore. And it's legal. It's legal to do that. But in our world, that's a really big problem. And it's what that does is it takes a perfectly well-insured patient, denies them that medication. There is no substitution. It's just not available. Because a lot of our new branded products are one of one. And so you have to then get the denial from the insurer, send that to a pharmaceutical manufacturer for a very well-insured patient. And that free drug program was meant for under and uninsured. But it's a denial now from a patient's insurer. So they do that to gain access to care. We're seeing a large growth in that free drug program with that particular subset of patients. That's untenable. That's not sustainable, everyone. Pharma will have to react in some form because it's going to drain their resources. And we're not talking about the insurer, the employer. If this happens to you guys as consumers, get HR on the phone. You know, it's designing your health benefit plan is one of 1,000 things HR does. They need to know how it's impacting their beneficiaries. And they can grant exceptions to you. But they need, maybe when health plan benefit design comes up that next cycle, if there's enough of you guys, they'll change that benefit design. So I don't know if that answered your question, but that's my soapbox.
You mentioned something interesting, that it's expanding into oncology in areas that we would have never thought before. But Dr. Kovacs, I'm curious, do you see this? I know what happened to me was in one particular class of cardiovascular drug, but do you see these types of exclusions expanding into other cardiovascular drugs also?
Well, we certainly do. And, you know, the American College of Cardiology spends a fair amount of time and effort and volunteer resources with dealing with some of these issues, such as formulary exclusions and the switching that goes on. Just an example, recently, you know, we've not talked a lot about heart rhythm problems, but we have formulary exclusion of one rhythm-controlling drug, dronedarone, for another rhythm-controlling drug, amiodarone. Now, the college does a lot of things, but one of the really important things, and I think it was mentioned already, is that the American College of Cardiology and our partners at the American Heart Association, we publish guidelines for treatment of cardiovascular diseases. And in this particular exclusion, we are facing the exclusion of a drug that is listed as a Category 1. This is a drug that should be available to patients for treatment of atrial fibrillation. But it will not be formulary. And we hear, again, well, we can make this switch, and you can appeal this, and we'll grant the appeal, but there's time burned on that. But then we heard another reason. We said, well, we're going to save the patient money because one drug's quite expensive and the other drug is not. But this is being looked at through a keyhole here of how a pharmacy benefits manager would deal with this. What's not been told to the patient is that, okay, drug X is here and drug Y is here, but oh, by the way, drug Y has a lot more toxicities, and oh, by the way, you're going to have to go for initial blood testing a couple times a year. You're going to have to have regular eye examinations. You have to have your pulmonary functions checked or x-rays done. You have to take time off from work to go do all these other things. So the cost is saved, but
not really.
Shifted.
I mean, they're so focused on the drug, they're not looking at the entire ball of wax, that total cost of care.
Well, and you mentioned that, you know, it's a class of drugs that can be very dangerous. So I'm assuming there's the potential for adverse events to happen, and that's got to be very frightening to your patients too.
Absolutely. So the patient is faced with additional toxicities, and then again, in terms of the physician-patient relationship. So you've written a prescription for a drug, based on shared decision making and that particular patient and their particular safety profile. But they go to the pharmacy and they hear a different story and they say, well, maybe Dr. Kovacs really doesn't know what he's doing, and we've got this other stuff that's just as good, and because that other stuff isn't even on the formulary. So it erodes that trust because the prescription is rejected. It interferes with the doctor-patient relationship, and ultimately it doesn't save the patient any money.
Well, you mentioned that there's the option of a patient to appeal. And Kathy, I want to ask you about this because I know the Affordable Care Act, you said that patients can file for an exemption when these types of things happen. But how, in practice, how realistic is that? And do patients even know that that's an option?
No.
No.
The answer is no. That's in the insurance plan of almost any insurer, is you do have the right to appeal. So it's not unique to the ACA. You know, it's in the Blue Cross plans, Humana, Cigna, Aetna. You know, patient always has right to appeal. Doesn't mean they're going to win the appeal. I've almost never seen a patient win an appeal unless they really dig in and take it a little further into the court of public opinion, or their, you know, again, their employer and the HR director. We do that sometimes. I will do a three-way call between the patient, their employer, and the insurer. And I make them explain to the patient what's going on, because I'm not going to be on the hook. And I want them to understand how it works so they can generate change. The patients out here from the leadership thing, you really do have a voice in trying to make this better. But it does occur. And again, you're going to spin your wheels on that. It might take 2, 3, 4 weeks. And that's time that none of us can waste in cardiology and oncology.
You know, it's interesting when I hear you say, okay, there's an appeals process, but very few patients actually are going to come out and win that appeals process. And that brings me to sort of consumer protections, is you've got this process, but it's not really working for patients for them to be able to stay on their stable medications. And so, Sarah, I wanted to ask you, you know, Congressman Dunn, you know, he's raised this issue. We mentioned vertical integration of the pharmacy benefit managers is a detriment to patient care and us being able to access the medications that we need. What can be done policy-wise at the federal level to ensure that, you know, the sanctity of the doctor-patient relationship, that when I go meet with my physician, that we're able to make decisions and, as Dr. Patel said, not have that third party in the exam room with us?
For sure. Thank you. I think, you know, there's a big focus on transparency right now, and I'm optimistic about it. There was a slew of committee hearings over the past month. Frankly, every committee of jurisdiction and more are hopping into the fight. You know, the Oversight Committee is taking a look this week. So a lot of ideas floating out there. But I think the good thing there is that we are advancing these policies. So you have a PBM package that came out of ENC. You have one that came out of HELP. You have additional frameworks being discussed. So I think the political will is there to actually sign these transparency measures into law. So these are things like requiring the PBMs to report to their clients and to employers, you know, actionable, I would say, information about what are these rebates actually looking like? What are discounts actually looking like? I think efforts to delink the PBM compensation from list prices is something that will be important. We've got to look at the alternative funding vendors that Kathy discussed, rebate pass-through. I think there's a lot of good ideas floating out there that are going to move somewhere, and the good thing is we're figuring out ways to come together and pay for them. There might be some discrepancies in the specifics, but I think that gets done this year. And then I think we can take a closer look with hard data and determine what we can do on a regulatory side. Unfortunately, it's going to have to be this transparency first, this sunshine, so we know what we're really messing with. But I mean, you can look at the earnings statements or the earnings calls of these companies, what 3 of them are in the top 5 of the Fortune 500 list. You know that there's a lot of money getting, there's savings that they're generating, but they're for themselves. They're not going to the patient. So how can we unstick that and then be more actionable about it all?
Right, and I think for me what's sort of heartening is we're not just identifying, okay, here's the problem, and we've been talking about this for some time, but now we're starting to see actual discussion at the policy level about solutions, and that's where I think all of us and our voices and sharing our stories, whether it's the patient or the clinician, to say, hey, here's what's happening. And that's how we can get some of these practices changed, is by voicing our concerns. So I wanted to make sure that this is a very active panel, this has been a very active discussion, to save some time for some of your questions. So I'm going to open it up if anyone has any questions for our panel at this time. And if not, I'm going to toss one out. And that is something we've not mentioned is state regulation. So I know we have activities at the federal level, we have activities at the state level. Do you find one more promising than another, or are there limits to, for example, state action of why you would want to do federal action? Whoever.
I can address the state of Indiana. Our legislature just finished their session. They challenged the hospital systems in the state of Indiana because we have healthcare costs that are well above the average for the United States. And so they have challenged us to bring those costs down, at least to the average for the United States. And the rebate system is one of those things that has been on the radar of the state legislature in the state of Indiana to again track where this flow is going. Is this money actually going back to the patients, or is this profit? So in Indiana, it's on the radar.
So do you see, is there, for these activities that are going on at the state level, Kathy, do you see a way that people can engage with those state efforts?
Yeah. Engage on your state level. Know who's in your legislature. I didn't know who was in my legislature until a few years ago when I started to take an active role in it. And figure out what they do for a living. Do you have pharmacists? Do you have physicians? And their loved ones are probably impacted by this stuff. Engage with them. Tell them your story. You are the consumer. You're the voter. And even if you're not the patient, the caregiver, a loved one. We talked about this yesterday. The pharma partners, you're all consumers of health care. And what's going on in the state and the federal level will eventually impact every single one of you. So it's important to know what's going on, to tell these people in Congress and at the state level your story and how the policies, good or bad, are impacting you and your family. We talked yesterday about it's just not the voice of the patient. It does impact everyone in that patient's life. The employer, the family, the children, the wife, time away from work. All of these things do matter. And unless someone says something against a policy that's out there, and you probably see this all the time, someone proposes a policy, sounds good, but unless someone speaks against it, how are you supposed to know anything? Know better. It sounds great. Engage, please. And, these legislators, they do want to hear your stories. They do want to hear how it impacts you. But go to them with an identified issue and an identified solution. We talked about that yesterday. We're not asking you to solve health care, but in a perfect world, what would you envision? And just throw it out there, and maybe if enough voices get out there, something will stick.
Good point. I think if we don't say something, then nothing changes. And I think we all agree the status quo just is not benefiting patients right now. Is there anyone in the room here that has a question? Okay.
Okay, can I interrupt for 1 second?
Yes, you can.
Okay. So I do a lot of work in oncology. I'm on the Hill quite a bit. So for the pharma partners here in the room and the sponsors, I just wanted to thank you guys, Patch, Dr. Patel and the pharma partners for putting this event on. Imagine what we could do if we empowered and elevated the voices of more patients. And, just imagine that. Cardiology, neurology, oncology. Imagine what we could do if we all kind of came together with a collective voice around a problem.
Well, and I think that's something we've learned is that working together, we're much stronger than working siloed independently. And as a patient, I feel so grateful to be included in these conversations. Because a lot of times you do feel very small and very tiny and like you don't have the power to change. But it's by coming together and working with organizations and working collectively that we really can get our message out and our stories out, and we can impact policy change that benefit patients. And that's really, at the end of the day, what every one of us is all about. We want what's best for the patient. We want, when the patient and the clinician are in that exam room, that we're able to make thoughtful, informed treatment decisions, and we don't have any of these outside considerations. You don't have to wonder when your patient goes to the pharmacy, are they going to be able to pick up what I just prescribed or not? And that helps everyone. It helps lower costs, it helps the patient, it helps the family, and everybody wins.
Well, I think you had a question.
Oh, yes.
Well, so you've talked about oncology. You get a cancer diagnosis, and it's the C word. And what I feel like we are lacking, at least when it comes to what's happening with access to cardiovascular medicines, is like there's not the big C with cardiovascular disease. And so how do we work together, like across stakeholder groups, with payers, with providers, with all the different patient organizations here, to kind of elevate the importance of treating cardiovascular disease and access to medications in the same way I think that there has been kind of galvanized support, with COA and other organizations to really combat and protect that patient-provider relationship?
All right. You want to go first?
Well, I don't want to take a back seat to cancer. we still are, we're some facts. Just, as was mentioned, Dr. Patel mentioned, cardiovascular disease is still the #1 killer in the United States. And we see patients come up and they look okay. But remind people that cardiovascular disease includes stroke. It includes being tied to a dialysis machine 3 times a week for the rest of your life. That these perhaps are the life-changing events that really impact people. When I talk to my patients are more afraid of a stroke than a heart attack. The heart attack is this abstract thing. The stroke means I'm paralyzed, I can't work, I can't talk, I can't enjoy my family. My life is diminished. So we need to get that message out. We need to go together. And I'm going to mention one other thing that I think this needs to be based on. This needs to be based on the science. And that's where your specialty societies come in, where the American College of Cardiology, the American Heart Association, American Society of Hypertension, Association of Black Cardiologists, these are the scientific truths. And we should be unashamed of giving the unvarnished scientific truth to state legislatures and to the federal legislature as well.
Now, I mentioned this yesterday. One of the things that we started doing in oncology years ago is we started collecting data from and I know you're familiar with this. And so we developed a form, very clear, name, insurer, and problem with the insurer. Was it, if you send it out to the specialty pharmacy, what's that delay? All of those things and how that impacts the patient, if it's a non-medical switching. So we started documenting all of those things. And we've collected over 1,200 of those stories across the United States, and we've submitted them in volume to Congress. We're on volume number 7 right now. Those have impact. So Dr. Patel, Patch, it's an easy little form. You send it to all of the practices that want to participate, and when these things happen, it's just easy information. You collectively gather them, you aggregate them, and that's one of the ways you elevate the voice, is by the impact. But it's showing every part of that, that line. It's talking about the insurer, the PBM, the delay in care, the outcome. So that's my challenge to you.
I think that's a great point. And on that note, I think we're going to wrap things up. And I want to thank each of you for being with us today and shining a light on why so many patients are being left out and excluded from receiving their medications. Thank you very, very much. Thank you all.
Please make your way to the buffet for lunch, and once you get your plate, please return to your seat for our next presentation, which will begin in approximately 20 minutes.
About half of American adults have high blood pressure or hypertension, increasing their risk of heart attack, stroke, kidney disease, and even death. But not all Americans are equally affected. The burden of hypertension falls disproportionately on communities of color. Compared to their white peers, Black Americans are 20% more likely to have hypertension, and they experience significantly higher rates of cardiovascular disease-related death. Hispanic Americans are more likely to go undiagnosed and more likely to experience kidney complications as a result of their hypertension. And Asian Americans face greater difficulty getting high blood pressure under control and experience more severe strokes. These disparities can stem from different factors, such as inadequate health insurance, lower income levels, lack of reliable transportation, less access to healthy foods, and language and cultural barriers. And the problem of hypertension just keeps growing. If things don't change, more than 25 million additional Americans will have hypertension by 2035. Now is the time for greater awareness, fresh approaches, and innovative solutions. The time for every patient, especially those disproportionately affected by hypertension, to have access to a treatment path that works. Now is the time to make hypertension history. It can start with sores on the legs or feet that won't heal, pains in the calves, especially when walking, or pale, even blue-colored feet. These are the signs of PAD, or peripheral artery disease. PAD happens when arteries, usually in the legs, become narrow or blocked, and certain factors make people more prone to the disease than others. People who smoke or are overweight are more likely to develop PAD. So are people living with type 2 diabetes, high cholesterol, or high blood pressure. The likelihood of developing PAD is also higher among people who are over the age of 50, African American, or have a family history of the disease. And when it comes to PAD, the stakes are high. If left untreated, the disease can cause a heart attack or stroke. It can also lead to amputations. That's why screening is important for people experiencing PAD symptoms. For people who are diagnosed with PAD, it's equally important to develop a treatment plan with a healthcare provider. A plan to improve quality of life and slow disease progression might include maintaining a heart-healthy diet, managing conditions such as high blood pressure, diabetes, high cholesterol, or obesity, exercising regularly, taking prescribed medications to reduce the risk of heart attack or stroke, or practicing good foot and skin care to prevent infections. Through widespread screening and effective disease management, healthcare providers, patients, and policymakers can work together to reduce PAD's impact in communities across the country. Learn more at advancedcardiohealth.org.
Non-medical switching essentially undermines what I went to medical school for. Our patients who have chronic conditions, they are extremely difficult to treat because we're juggling different disease states. You end up using 2 to 3 pills for hypertension. You end up using 2 to 3 pills for diabetes. You end up using 2 to 3 pills for heart failure. You could end up using 9 to 12 medicines when we have finally got to a therapy that works. And then we get the phone call that the medicine has been changed. That's the ultimate nightmare for the physician. Non-medical switching is when insurance companies enforce switching therapies for financial gain. Unfortunately, we have had victims of patients due to non-medical switching. Patients who are on good blood pressure medicines which were working great. they were switched and the blood pressure spiked and they went on to have a stroke. I would like to be involved with healthcare plans when they decide about which patients of mine get non-medical switching. Patients, they are my extended family. And with that, they do bring an element of trust. Non-medical switching is for populations predominantly, but we're not treating populations. We're treating patients one at a time.
Feeling short of breath or fatigued from handling daily tasks. Swelling in the legs, ankles, or feet. Persistent coughing or wheezing. These can be symptoms of heart failure. Heart failure occurs when the heart cannot do its most basic job, pump blood and oxygen throughout the body. There are two main types. When the heart muscles are weak and cannot pump enough blood to circulate, that's called systolic heart failure. But when the heart muscles are stiff and cannot fill up with enough blood, that's called diastolic heart failure. Today, over 6 million Americans, men and women, live with heart failure. The disease is linked to high blood pressure, coronary artery disease, diabetes, and obesity. And people are more prone to heart failure if they are 65 or older, African American, or have a family history of the disease. If left untreated, heart failure can be deadly. But there are proven strategies and treatments to reduce symptoms and improve quality of life. So watch for the warning signs. Stay physically active. Maintain a heart-healthy diet. Take medications as prescribed. And visit your healthcare professional regularly to get the treatment you need to live a longer, healthier life. Learn more at advancedcardiohealth.org.
Ladies and gentlemen, please take your seats. The program is about to resume. Our lunchtime conversation is using stories to advocate. Please welcome to the stage Ryan Googe, Executive Director of the Partnership to Advance Cardiovascular Health, and Kenneth Moten with Actum.
Okay, everyone. Okay, while we are enjoying lunch, this is our fun conversation for the day. I hope everyone's enjoyed the panel so far. So with me today, I have Kenneth Moten. Kenneth is a veteran television journalist who brings nearly a decade of national broadcast experience, including past assignments reporting from the White House and Capitol Hill. Kenneth was previously, well, I joked yesterday, if you feel like if you're like, I think I've seen this guy on TV, you have. Kenneth was previously an anchor and correspondent for ABC News, covering national and international news stories for the News Network since 2015. He reported for ABC's top-rated programs, Good Morning America and World News Tonight, and also served as the co-anchor of the #1 overnight news shows, ABC's World News Now and America This Morning. As a North Carolina guy, I'm sad to say that Kenneth is from South Carolina. as a proud graduate of the University of South Carolina. So thanks for being here.
Go Gamecocks.
So I wanted to have this conversation with Kenneth today because we talk a lot about how we talk to legislators, policymakers, regulators. But as you all know, being able to mix it with the media is also really important. And so Kenneth joined us this weekend for our Cardiometabolic Leadership Academy to work with all of our CLA graduates now to help them talk about how to give their story to the media, which I think also obviously translates to how you talk to a policymaker, because as everyone in this room knows that's ever talked to a policymaker, you don't have a lot of time. And that's the same case with the media. So my goal with this conversation is to get kind of in the head of a reporter a little bit so that everyone here can understand like what reporters are looking for and how we best communicate so that we can be most effective in our advocacy. So, but before we even get to all that, I want to ask Kenneth, I guess you would call this the human interest portion of a news story, right? So tell us about, how you got in the news business, what brought you there, that kind of thing.
Yeah, definitely. Well, thanks for having me. The Partnership to Advance Cardiovascular Health. I have enjoyed working with you guys so much. Thank you. Thank Allison, Courtney for allowing Actum to come in here and talk to incredible patient advocates. Right now I'm using my lower voice because I get really loud and I got a microphone on, and I always say I don't even need a microphone. The patient advocates know I'm loud. I want to say that it's just been an incredible experience getting to know the patient advocates and getting to know you guys and what you bring to the table and how you're changing policy in this country and making sure that people hear you and hear the message. And so I just want to applaud you as well. Now, my favorite subject, me. Yes, I've been a broadcast journalist for nearly 20 years, and I just made the change about 6 months ago. My former employer is across the street, ABC News. The DC bureau is there. The headquarters is in New York City. And I spent 8 years as a national correspondent, overnight news anchor, filling in on our ABC News Live. I've been on GMA3, done all of it with ABC and traveled all over this country. My first big story, actually, at ABC was the Charleston Church Massacre. So I started June 15th, 2015, and then 3 days later, the church shooting happened. I was back in my home state where I had just been a week before on vacation in Charleston, and I was back covering that story for all of our ABC affiliates, so it was a really sobering moment. National news, of course, there are a lot of negative news stories I've done, but there have been a lot of fun ones too. One of my last big assignments for ABC, I was in Tokyo for the Olympics. Always wanted to cover an Olympics, and I thought I had to work for NBC to get that done, but ABC sent me over, and it was a good time. And then before that, local news. I'm a local news guy because I believe all news is local, so I jumped from the Carolinas, from South Carolina to North Carolina, Raleigh, to Orlando, to Philadelphia, and then to national news.
What do you think the biggest difference is between the local news and national news?
The egos. Now, when it comes to local news reporters understand, local journalists understand that it's local politics, local policy that really impacts the pocketbook of everyday Americans, right? And so those local stories matter, those community stories matter. When we talk about advocacy, I've seen so many people that, countless number of folks I've interviewed for groups like Patch, people who are just trying to get the message out about something that's happening in their community, and they're advocating for themselves, for their community, for others. And I've seen powerful things happen in those situations on the local level. On the national level, everybody focuses on national because you sit and you wake up in the morning, you might turn on Today's Show, GMA, CBS, and everybody was like, what's going on nationally? But I'm like, but did you watch your local news? Do you know what your local headlines are? What's going on in your community, what the mayor and the city council may vote on Tuesday or the next day or whatever? And for national news, I feel like it's a 35,000-foot view. And they come in, they swoop in. And I remember I always called that local news station and be like, I'm here, just so they know that I'm like in your territory. This a place, a city you cover, a market you cover. Tell me what I need to know, because national news reporters just swoop in and then they're out. Yeah. And I may tell a 1-minute story on World News Tonight with David Muir, and then I am out of there. Yeah. So that's one of the biggest, bigger differences there.
So tell me, what's the most impactful event you covered, and why do you think it was the most impactful? And that could be impactful for you or impactful for the world.
Yeah, I just think that anything involving children always impacts me the most. And so because I'm a good old Southern boy, and because of how I grew up and how my parents raised me, I'm always thankful that I'm doing the story, because unfortunately in our business, in the news business, you find people who don't have the same morals or values. And for me, it was important for me, and I'm a man of faith, if I was on a crime scene, a shooting, mass shooting, something where a child was killed, anything really, I'm about to go into someone's home, knock on their door after they've lost a loved one, which is one of the most intrusive and horrible things, you can imagine that a person is going through, and then you've got a reporter knocking on your door. I always would sit in the news van and say a prayer. I say a prayer because I want to make sure that I'm a vessel for telling and conveying this message of the person I'm trying to speak with, I'm about to speak with. I'm praying for that I won't sit there and just start bawling, start crying because of a horrible event. I'm just praying that I bring truth to power, and that I'm an honest broker, that I'm a truth teller. Those are my goals as a journalist. And so I think it served me well. I mean, there were a lot of tough days, and from fires, and just I was in Las Vegas. I was covering O.J. Simpson getting out of jail. And then that weekend, I was going back to L.A. because the O.J. story was over. GMA had another reporter who had been covering during the weekday, and I was on the weekend. And then the Las Vegas shooting happened on Sunday evening, and they turned me right back around. And that whole week I covered, 500 people were injured, and I think it was 50 plus killed. And people ask, do you get numb to those things? And I'm like, no, thankfully I don't. Mm-hmm. I will do my job, and I think I will do it well. But it is tough to go through those stories day in, day out. And so after 20 years, I was like, I'm going to make a little bit of a change, because that's a lot. And for those who are still in it and been in it longer, I commend them, and I'm rooting them on.
So that actually gets me to a question that I have here for you. So as a reporter, I'm trying to put myself in your shoes. You arrive at an assignment to a scene, to the Olympics, whatever. What are you trying to capture for the audience? I mean, are you just trying to are you trying to just get the straight news, like, this happened, that happened, or what are you trying to bring to the piece that, I guess, in a way, makes it a great news story versus just covering events? Yeah. So when this University of South Carolina, a little plug for University of South Carolina, I call it the real USC. No offense, Southern California folk. Has a great journalism program. And what I learned was to do the ABC, to just put the facts out there as we know them. And then as you go on, and as you get more experience, then you try to give a little bit more to make sure you're more compelling and all these things. And when I say more compelling, I don't mean get up there and exaggerate, because yes, reporters have you see the news people, they have a tendency to exaggerate. Surprise, surprise. But my goal was always I don't want to be a distraction. I want to give the details. I don't want anybody to say, oh, he has a political leaning. And I know we can talk more about that later, about the changing landscape of just news and the world of media. But I wanted to make sure I just give you these details and you decide. And to be honest, as a journalist, when I would get the hate emails from both sides of a story, I actually feel like I was like, did a pretty good job, right? If you get someone who's like, oh, that was an amazing story, and I'm like, dang it, what did I leave out, or did I? But if they are like, what is this part and then this part, I'm like, okay, well, both sides are mad. So if everybody's mad at me, I must have done something right. Yeah. So let's talk about the CLA, because you were integral in that and helping us pull that together. So for those that are unfamiliar, what we were attempting to do with the Cardiometabolic Leadership Academy is to take, and we worked with all of our partners. I should back up there. We worked with all of our member organizations and asked them, hey, give us the patients that you work with that know how to tell their story. They know that piece of it. And then we were going to try to add an extra element and talk about policy. Because as you all know, and you talk about it today, I mean, policy is complicated, it's heavy, and it's just difficult to talk about. So what we were trying to do in the course of just a couple days is, one, try to give everyone kind of an overview of all these utilization management problems that we talk about at summits like this, and then why those things happen. And then how do you infuse your story into it? And that's where Kenneth and his team came in. So we had 14 patients that were here with a range of heart conditions. And, you've interviewed lots of people.
Yeah.
I'm sure some people that have dealt with, health conditions and those that have not, range of issues, public issues that impact the country. I'm curious of your thoughts on the participants and how they did.
From day one, we did interviews, these mock interviews, virtual, that every patient advocate loved, right? You guys loved them, right? Especially, we asked 3 questions, and it's the third question everybody's talking about because we threw in a political question, and we asked, who's to blame for the issue, Republicans or Democrats, the Biden administration, and we wanted to see how they would react to it. A very partisan question. And I will just say, you all did just incredible. It was an amazing group. It's just an amazing group. And what I found from the start, it's just genuine, authentic. And that's what we're looking for in our industry and media, is a genuine, authentic person, because we know where the world is, and it just feels like sometimes we're losing that authenticity. Or people are just saying what they think you want to hear when they go on cable news or whatever. And I found a very passionate, a group that just wants to be better. There were some people who have media experience, and they're like, but I still want to know what you think. What are your pointers? What are your tips? And so our team just tried to hone in on the messaging for Patch and what you guys wanted to do through CLA. And I just feel like the patient advocates really nailed it.
What was the biggest improvement?
The biggest improvement is not being long-winded. We all happen to be a little long-winded, especially when you know about you, right? When you know about you, where you come from, what you've experienced, you just want to talk about it, right? I could sit here and tell you about news all day long, tell you about Abbeville, South Carolina, which is where I'm originally from. There's a patient advocate who actually lived in who actually lived in my hometown. Her son was born in the hospital I was born in, and we find this out during the mock interview. You live in Alabama, right? And I'm like, what are the chances? And Abbeville, y'all, is like the smallest town, so that was an incredible moment there. But what I just thought was, like, you guys just went in it with your eyes just like kind of wide open, and we said you're going too long. I kept using the word be concise, and then when we did mock interviews yesterday at the end of training, you guys cut it way down. They cut down their time because we say give the 30-second elevator pitch about your life, about your story. And that's a very tough thing to do, especially when you're dealing with policy, you're dealing with numbers, facts and figures. But for our industry and news, it requires that. It requires that concise messaging so that you can essentially make sure the reporter gets your story right and tells it in an effective, like you're an effective advocate so they can have an effective story.
I gotta say, I'm glad Kenneth doesn't, I didn't have to go through the training because Kenneth would also be telling me constantly, Ryan, cut it short. As our comms people also know, Ryan, what does Allison say? Turn up the music, the Oscar music, get him off the stage. So also, you all should know that we made Kenneth read all the material too. So
yes.
Kenneth had to read the material. He had to kind of go through an abbreviated version of the program. So I'm really curious of what you thought of the curriculum as you dug into it.
Well, reporters know a little about a lot, I guess. That's what they say. Like, we're pretty dumb about a lot of things. We have to go in there and then just learn about, everything from, what's going on in the state legislature to Congress and, just across industries, right? And so I remember reading this manual, and I just thought, my first thought was, this is really put together very well. I mean, like, I'm not just saying that just because I'm here. Way to go, Allison. I know it was all you. But it really was put in a simple way, because I was thinking I was about to turn page 1, and it's going to be all of this complicated language. And I just felt like there was so many explanations and good information in there. It's enough, because what I do even as a reporter is when I have to take something in and spit it back out, like especially in a quick turnaround, I'm taking all this information in, and I felt like after reading that manual, I could go and give a few minutes on what I learned, and then because of my memory, I'm going to lose it in a day. But I'm pretty sure the patient advocates are a lot better than me on that.
Well, it's interesting too, because you say that we write and try to do everything that we do, from the videos that we've seen today to the infographics that we do and the white papers that are even like longer form. We try to write it for an audience that's coming to it, fresh, right? And in some cases, that's a reporter that's coming to it fresh, and also, importantly, a policymaker that's coming to it fresh. And so I'm glad that that kind of translated.
Even your media bullet points were spot on. Because, you know, when someone else is talking about media, I'm like, oh, let me see what they say about us or how we, and I was like, no, that's right. That is how we operate. Yeah, that's it.
That's great.
Yeah.
So let's back it up to 30,000 feet, because I'm really, personally really curious about your thoughts on this. So I was trying to think about how to frame this question. You know, I want to get into like the changing media landscape, because I remember, I think it was like 2008, and Howard Dean was running for president, and they were talking about this newfangled thing that he was utilizing, and it was called this Twitter, right? Yeah. And it was like this, it was at the time, it was like breakthrough that he was using Twitter to like communicate to his audiences and that kind of thing. And that just, to me, you know, just alone speaks to how far we've come in terms of how things have changed with media. So I'm curious about your thoughts about how things have changed with media, either the how it's delivered, or you know, the content itself, and maybe your thoughts on how to break through the noise, because I would imagine you're probably going to tell us there's a lot more noise now. But
yeah, I was going to say in the past 20 years we've seen such a drastic change in the media landscape, but in the past 10 years, especially with Twitter, Instagram, all these social media platforms, with all the streaming channels for all of the broadcast networks, the cables as well, things have changed more than I ever thought, more than my journalism professor would ever think, you know, would have thought. This is not Brokaw's news. This is not Peter Jennings' news anymore. It has totally changed. And I will say, I won't name which organization, but there was one point where we were doing stories based on the number of views and clicks on YouTube videos, the viral videos. You know, news loves viral videos. And they were like, it has this many views. And I was like, well, it's not really that, but it has this many views, so let's do a whole story on whatever this viral video, you know, and make sure you get it in the piece and show it a few times. And I wanted to dig more. I wanted to go after certain stories. I wanted to have more substantive conversations. And I felt like, and I feel like, when it comes to the media landscape now, I mean, there's a number of things. I mean, we could talk forever about how it has to be flashy. It has to be, you know, I will say I came from a network at ABC. They weren't about being first, but I saw so many news organizations that wanted to be first, that had to be first. Like, that is a real thing. And there's some things I think that media is thrown under the bus for that I don't think is necessarily right or true. But we also don't do ourselves any favors in media about how people operate. And I just tried to focus on me and how I was doing the job, because I saw so many examples where it wasn't being done right. But again, things, because of Twitter, because of social media, there are pros, again, because when I started in journalism, you had to put a mast up in the air in the news van, right? To even get what we call a micro. I don't want to get really technical on you guys, but we had to do all these things to get a live shot. Now, we literally can use my phone. Right. I could be live in this room for national news in seconds.
Right. So how do you break through that noise?
So breaking through the noise, you just got to jump up and down, head on fire. No.
Protest.
I would say really effective messaging and timing. Yeah. When it comes to news, like we were even saying, you know, during the CLA weekend, of like, you want to pitch something, maybe don't pitch it when like there is a mass shooting in your town. And I know that's a horrible example, but that is true. Like, you just won't be able to cut through a major news story, either in your local or in your national news. There was even a few weeks ago for the coronation across the pond. We're like, well, that's over there, that's not over here. I'm like, but if you watch on Friday, all the shows, GMA, Today's Show, see, everybody had anchors over there. That's all they cared about, and they dedicated a lot of programming. So really, globally, for national news, you have to see what's happening in the global headlines before you try to pitch something.
I really take the timing, your time about timing, because, you know, from a policy perspective, we all know that these things move quickly, sometimes slowly too, but a lot of times, you know, legislation or a current event is happening quickly, and you have to like just catch it at the right time in order to insert that patient or that provider to like get your point across.
Not only do you have to be, and you have to be consistent with making sure, because reporters also, you know, because they're skeptical, if you just pop up on them, they're like, oh, let me vet you a little bit. But if you are consistent, like, okay, well, Ryan's been reaching out to me. Let me research his group more. And then you establish yourself as a leading voice where a reporter knows they can come to you. Hey, Ryan, Allison, I'm looking for a person who is a father who has had a couple of heart attacks, and this legislation in this area in our state might impact them. I gotcha.
It takes time, Kenneth.
It does. But as you know, it's not only as a network, but it takes that time to build that credibility.
Yeah.
And if people know to come to you and reporters know to come to you, they will.
Yeah, absolutely. Well, before I jump to our final few questions, I wanted to ask if there were any questions in the room for Kenneth. Anybody?
You guys have been doing my favorite pastime, which is eating and watching something.
Yeah. All right, so we'll do a quick lightning round. We'll wrap this up. So I want to do a lightning round with Kenneth because we were just chatting behind the curtain. You know, some of these podcasts and things that I listen to now, I sometimes find that you learn more about the topic sometimes from the lightning round with the person they're interviewing because you just understand where they're kind of coming from. So I've never done the lightning round, so you're my first time, but let's go.
Let's do it.
All right, favorite news anchor, past or present?
Okay, so this is a tough one because my favorite one got canceled. They all keep getting canceled. They do something, they get canceled. So I can't say that one. Jennings, Brokaw. I have to give you two, just because I grew up watching Jennings with my great-grandfather. That's how I kind of fell in love with news. Like literally, I was like a little boy in South Carolina, in a rural town. I used to run around dirt roads with no shoes. I'm that country. And then my great-grandfather, James Moten, would sit there and watch Jennings every night at 6:30. And I just thought, and he passed away in late 90s, and I remember thinking, what would he think that his great-grandson in rural South Carolina, this was a black boy in South Carolina, like his last name is up on the screen on national news. And so Jennings is always one of my favorites, but Brokaw's because I just grew up watching NBC as well. So
absolutely. Okay. What book are you reading these days?
I've got Spare on the coffee table for my vacations this summer. So I'm going to knock that one out. And then I'm finishing up this book on called How It All Blew Up, which is just a young writer who he's gay and he's Iranian, but he's in the U.S. for his parents came to the country and he just didn't want to tell them, so he ran off to Italy for a month. And so it's about his story.
Oh, yeah. All right.
Yeah.
Favorite podcast you're listening to?
So I'm not a big podcast person, but I'm a big supporter of my friends and a lot of broadcast friends. And so there's friends who have a podcast called What You Heard. And they just talk about all types of pop culture things that are going on. Like they were just talking about John Moran, which was, it's kind of interesting to hear people's takes because there's so many takes on it. So,
let's see. What do you think in the news or commentary business, or who do you think in the news or commentary business is doing something interesting or different?
Ooh, it was me when I was in. No, I'm like the biggest fan of like a Robin Roberts because she's as genuine and authentic as it gets. And you meet people sometimes and you're like, are they gonna be, who you hope they'll be, and you're looking for ways they're going to disappoint you, and the woman never disappointed me. So I always think when you bring that to the table, when you're doing this job, it always shines through, and I'm a big fan.
Best restaurant in D.C.?
Oh, so I just read an article a couple weeks ago that said anyone who thinks Founding Farmers is, you're not real, but I really do. I like Founding Farmers, Lincoln, all of
I can get behind that.
And then they're like, and there's other Italian restaurants besides Cafe Milano in D.C., which is, where all the politicos go, as some of the D.C. people might know.
All right, last two. Favorite city you've had an opportunity to travel to for work?
Ooh, I think, in the U.S., I've been all over the place in so many cities. And I can only think right now of I went to Tokyo, and that was a great experience, but that's a tough one. There's just so many.
Yeah. I'd agree with that. Every place has its charm.
And I ate every single last place. There was one summer, y'all, I gained so much weight. Traveling around for ABC News. That's not good for camera work, by the way.
Final question, little known fact that you would share with the group.
Ooh, okay. These are great reporter questions. I need to turn the tables on you
I
and
know.
ask.
Listen, you're not doing that.
Okay. At the University of South Carolina, I was a drum major.
Cool.
The conductor of the marching band, 400 people in the marching band. The last 2 years, first 2 years I was in the drum line, and then the last 2 years I was a drum major. So staying on the 50-yard line, conducting, like literally, there's nothing like standing on a football field in this, the South loves football, SEC. And I'm the only one on the field, 50-yard line, that feeds your ego. And like the band's on the outskirts and 90,000 people are cheering, waiting for you to call the band to attention. And, you do blow the whistle and they all, march out, you do your salute and you conduct a bunch of songs. And it was just a great couple of years doing that. And then I'll leave you with this, is in 2006, I was on a game show.
You want to guess which one? Do you want to
Does any guesses? Any? Nope. The Price is Right.
Really?
I was a contestant on The Price is Right with Bob Barker, and the very possible last chance to get on, I got I bet right. And I got on. I won a kayak, a clear kayak, which I later sold.
You still have it?
No, I sold it. And by the way, they do not let you take the money. You're like, can I take the money? And the woman was like, no. And I spun the wheel, got 95 cents. And then on my first go, it was really heavy. And just seeing Bob Barker in person was just incredible. And then I went to the Showcase Showdown, and then I overbid.
Is this on YouTube? Can we find it?
It is.
Okay, we'll find it later. We'll send it around.
Yeah, I might send it to the patient advocates after what we put them through.
Yeah. Well, Kenneth, thanks so much. Yeah. Thank you all.
Thank you, guys. Appreciate it.
So, am I still on? Okay, real quickly, what I want to do is I want to bring all of the CLA patients up here, please. And we're going to take one photo with Kenneth, and we'll break real quickly before our last panel.
Thanks, everyone.
Our fourth panel is Novel Nursing, helping patients adapt to medical innovation.
It's a disease that occurs when the heart muscle thickens, making it harder to pump blood. HCM can lead to heart failure and ventricular arrhythmias, which can lead to sudden cardiac arrest and death. An estimated 1 in 250 people have HCM, but a large percentage of patients go undiagnosed. That is because reaching a diagnosis can be tricky. The most common symptoms are shortness of breath, heart palpitations, lightheadedness, chest pain, and fatigue, which means HCM often gets misdiagnosed as exhaustion, asthma, anxiety, or panic attacks. Receiving proper screening is essential for patients to receive an accurate diagnosis. An echocardiogram is most commonly used to diagnose HCM. Family history should also be considered. Parents, siblings, or children of an affected person have a 50% chance of inheriting HCM. For many patients, an early diagnosis could mean life or death. So healthcare providers should familiarize themselves with the signs and symptoms of HCM and encourage more patients to undergo screening to determine a diagnosis.
All right. Just wanted to thank you all for being here and thank Ryan and his team for doing a wonderful job putting this all together. I'm Ross Hadley. I'm a project manager for the Hypertrophic Cardiomyopathy Association. It's kind of like Hair Club for Men. I don't know if you remember that commercial. Maybe I'm dating myself. But I joined the organization after I was diagnosed. And so my standard joke is it's close to my heart. Yeah, sorry. I was diagnosed with non-obstructed hypertrophic cardiomyopathy after AFib. So I wanted to thank my nursing friends who have contributed to my life so far and to my children and my family's life. As you know, hypertrophic cardiomyopathy is an autosomal dominant disorder. So if you find one, you find lots of people. And that is the challenge and the opportunity for healthcare. We've always been the island of misfit toys of healthcare. We didn't have an on-label indicated drug. And myosin came along, and now HCM as a home. And that has created a lot of excitement in our community, a lot of excitement. And our patients are really excited to experience or have the ability to experience a myosin-inhibiting drug, but it brings challenges as well. I want to introduce our panel. Amy Martzoff is a senior advanced practitioner at the Hospital of the University of Pennsylvania, where she's worked for the last 16 years. Yes. She's currently the lead APP in the Penn Center for Inherited Cardiovascular Disease, where she works with a comprehensive team of MDs, NPs, RNS, and genetic counselors to manage cardiomyopathies that are genetically mediated. Penn Center is a recognized hypertrophic cardiomyopathy center of excellence, actively trying to advance the clinical care of HCM patients. And Sue Philpott has worked as a registered nurse for over 2 decades, serving the ICU, cardiac cath lab, and outpatient cardiology units at Corewell Health, formerly Spectrum Health in Grand Rapids, Michigan. Sue has served the HCM clinic since 2017 after it received its certification. And since we only have 25 minutes, we're going to get right to it. We didn't get to go to the polish session, so we're just going to talk. So you all get to listen, and please feel free to ask questions at the end of the session. Amy, it's been a little over 1 year since cardiac myosin inhibitors have been introduced to patients. How's that going?
Well,
it's going great from a patient perspective. It's been a real joy to have something that actually treats patients so effectively. And it has been quite a challenge, a brand new type of therapy, a lot of things that go along with it. And what I mean by that is the FDA approval that was given includes a REMS program, a safety mitigation program, a lot of screening and monitoring, a lot of time. Sue, you would say the same?
Absolutely. We love how our patients feel on this medicine. It's improved quality of life so much, but it has created a lot of challenges on our side of things. The paperwork involved is really intense. The prior authorization process, very difficult, and then appealing the denial of prior authorization, and then the whole emotional part for patients too. It's such a hard process to get this medication approved by many insurance plans.
I think the first part of having this drug available to patients has been planning, and then more planning. The drug's approved. It requires a follow-up echo at week 4, week 8, week 12, and then with every drug change. Currently, I think across the country, there's difficulty in hiring enough sonographers to do this. There's a shortage. There's also a nursing shortage. And we're trying to get this done so our patients can get this. And it's time-consuming. And I think one thing that may have been echoed throughout everybody's presentation was that patients need to feel empowered and understand what's going on. And we really take pride in that. So we do a visit really going into depth, explaining the drug, the potential risks, potential side effects, benefits, what to expect. Bring your planner with you because we got to plan out all these visits, and we need a whole team to be able to do that. Is that similar to your experience?
Absolutely. Yeah, our process is a little bit different than what you've described in that we divide up some of the duties, but we work as a team to try to get the medicine for patients. And we've learned so much during the time that we've been using the medicine as far as patient education up front. The patients that we're looking at putting on this med, we explain now that it is a difficult process. There's many steps. You're going to get a lot of phone calls, not only from us, but from the pharmaceutical company that makes this medicine currently, and from nurse navigators and specialty pharmacies, because this medicine is only distributed by specialty pharmacies. So we've learned so much about educating patients ahead of time, that it's a hard process, but we will help them through with it.
Yeah. Patients are really excited about these new therapies, but there are the realistic challenges for both the patients and for the nursing staff within the facilities. And access is different based on the areas where they might be living and whatnot. Tell us a little bit more about the 30-day window challenge.
So I think the 30-day window challenge is the patients are only given 30-day supply of this drug. So you have to be organized ahead of time, because getting an echo within 24 hours, realizing you haven't planned ahead in my facility would be quite difficult, and I think in many facilities. So you have to set this all up and arrange this. And I think I joked on one of our discussions that the best day of clinic is the myosin inhibitor clinic day, because you see these patients who are feeling great and are really excited, and some I've known for decades, and this is lovely. The worst day is the next day when you have to gather all of your data, submit it all, make sure you've called all of the things in, called the patient, told them to set up drug shipment, or else they're not going to get their 30 days because we're cutting it close now. Make sure that there's no FedEx problems in shipment, that there's no snowstorm, etc., and you have a window of just a couple of days to do that. And if there's any snafu, be ready for you to take that. So, if your family has an event that night, you better get started in the morning, because if something comes up later in the day, you're not going to get to it, or their patient's not going to get the drug. And that's kind of a hard situation to be in. We love our patients, but it becomes difficult.
Sue, you had talked about a REMS program, and REMS is new to our community, and the specialty pharmacy concept is new as well. Can you explain REMS to the audience and what it means for access?
Okay, now let me remember if I know what the acronym is. It's risk evaluation and mitigation strategy. What
does it mean to you, at your work, though?
Well, you might not want to know. But my hair was brown before I started doing REMS. So the FDA is requiring for this medicine, as Amy has mentioned, that in the initiation process of the medicine, which is the first 12 weeks that people are on therapy, that they must have those echoes at 4, 8, and 12 weeks. And there's online work that we need to do to answer the questions that are posed for the FDA in order to continue therapy. So that's basically what that is. It's an online program to continue therapy and to ensure that people are safe, that their ejection fraction, their heart muscle strength stays normal during therapy.
And just before, while we were having lunch, we were talking about the challenges that the specialty pharmacy process and the education of both your docs and your patients on handling the new myosin drugs cuts into your patient time. Yes. Either one of you want to pick that one up?
It cuts in a lot, actually. So, we understand the safety needs. I think so. Doing the REMS program is a little bit more. I agree with that because of how this drug works entirely. But I think the modifiable thing is much more the back and forth with getting the prior auths and the time-consuming nature of that. I'm not a pharmacist, and I don't have access to certain ones of the programs, of what exactly needs to be done. Oftentimes I'm called, given a number, told that I need to do a verbal prior auth. I could call and get a number that's non-working. I could sit online for 30 minutes before I get somebody who tells me this was the wrong number to call. And that scenario can happen over and over again. And again, we're now on a 30-day window of getting drug, and these things pop up. It's just very difficult. And meanwhile, the patient who's like, I'm feeling great, please get this for me, please get this for me at the same time. Of course we want to, but sometimes it's quite difficult. Are you having the same experience?
Absolutely. We've had difficulty with some of the specialty pharmacies, like you said, getting to the right person. I've had to spell the name of the current medicine to the specialty pharmacies, and they have no idea what I'm talking about. It's very time consuming, and it takes away from our time with other patient needs.
And I think we could have I have about close to 70 patients on a myosin inhibitor therapy. And, if each one of these takes about an hour, that's about 70 hours. I think Dr. Patel had talked about 37 hours of doing prior auth. That's a full-time job, so that's one nurse full-time. I'm a nurse practitioner. We did not have the nursing support to do that, so I do that on my time in addition to seeing the patients and doing all of my other work that has to be done. So it's just an unnecessary time warp, a loss. And like I said, I could have more patients on.
And it's not patient time, and it's not billable time.
No, all of that's just considered administrative time, which I don't know how everybody else's system is, but I think in the way of the world and kind of cuts and limited nursing support, that very much matters. That's time that nurses sometimes are having to come out of clinic, sometimes aren't getting to see patients. This is time away from patient care, which is just entirely not what people want to do. It's also kind of hard to hire a nurse and say, we have this really great nursing job. You know what, you're going to see patients and do this. Oh, but 25 hours is going to be on the phone for prior auths. Who does that appeal to? Is probably not the nurse you want, who really wants to engage patients, take care of patients, et cetera. But it's a burden that's current.
Can either of you talk about your satellite facilities and echoes as well? Because in larger health networks, you know, you're drawing from a larger area. And right now, you're only dealing with the obstructed patient population.
Mm-hmm.
With trials coming down, and assuming approvals happen, you're also going to have the non-obstructed and potentially pediatrics. So your referring facilities are going to increase as well. How do you map resources for something like that?
That's difficult. I mean, at this point in time, with the amount of details that are needed, we're having everything done at our main facility. We tell patients that right up front, even if it's a travel time, et cetera, that's part of what they're signing up for with this. The way that the echoes have to be structured, the training that has to go into them, and the kinds of decisions we're making based on those echocardiograms, we just haven't been comfortable moving that. We hope to do that in the future, but at this point in time, we're not.
That's exactly what we're finding too. We have a more rural population in Michigan, and we tell patients up front that they will be required to come to our main facility in the Grand Rapids, Michigan area to have their echocardiograms and their appointments. It's hard work to even get them on the same day sometimes. And it's a big commitment for the patients. They feel so much better on the medicine. They're willing to do it, but it's hard, especially younger population that's working. They have to take time off of work. They have to, and bad weather happens for sure where we live, and it's a big commitment for the patients.
Well, you all have done an excellent job of moving us into the next question. Nurses play a crucial role in educating patients and managing onboarding. Can either of you speak, or both of you, take turns, speaking to the unique challenges that this patient population has in terms of understanding the sign-up paperwork process and specialty therapies? Because it's a whole new world.
Yeah, I think that it takes time to really sit with patients and explain all of this, of what exactly it's going to look like, and then that there's going to be big things that you don't expect to happen, like changes of insurance, middle of therapy, somebody loses a job, somebody loses their insurance, a patient turns 26 and is no longer eligible to be on their parents' insurance. The idea that you can't go to CVS and get this around the corner, that everything has to be timed and how much responsibility is. I always tell my patients, you're so used to calling me like, Aim, I'm in trouble. Like, I just need you to do this, and I promise you I'll come in. I say, if you do that, my hands are tied. I won't be able to help you. So I think these are the conversations that we have to have up front, and they have to know, but that will inhibit some people from doing it. Then when they hear how well people are feeling, it's a balance, and it's challenging. How about you?
Very much the same. It has, as we've gotten into the process further, I think we understand it's a complicated process. When we first started, we did not even understand what some of these what's a specialty pharmacy? Why can't they get this medicine at their local pharmacy? And even things as far as that, the specialty pharmacy part of it, patients have to be, or one of their family members has to be home when the drug is delivered to sign for it. Otherwise, it will not be delivered. So they even have to coordinate things like getting the medicine every 30 days. One of the specialty pharmacies that supplies this medicine requires us to send in a new prescription every 3 months for the same medicine, same dose. So you have to remember, not only these echoes, get those done, have them be seen. Make sure you fill out REMS. Oh yeah, they need their medicine renewed again. It's just, there's a lot to it.
And the patients can't leave for more than 30 days.
Well, that was going to be my thing. Have you experienced anybody that's feeling so good that they decide to go on a cruise?
Yes, but we've timed the cruise.
Yes.
Okay.
We have to.
I mean, I think my hardest patient is somebody who is from a foreign country and lived through the pandemic here and was so excited to feel better. And she wants to go back and see her family in India, but she can't go for more than 28 days, and that's not cost effective for them. So they're trying to work out options, but my hands are tied because I have no options at this point in time.
So we've talked about how excited the patients are and the challenges of education and onboarding and whatnot. But let's talk about a little bit more about the time cost of getting approval and the specialty pharmacy barriers.
We could talk a long time about that, as you see us joking with one another, because it's we have some informal networks about getting this drug up and running at centers. How are you doing? What best practices are? We're all trying to learn off each other. Poor Ross had to sit here, and then we were chatting the whole day. What do you do? What do you do? And trying to think about what we could do different at each other's practices, even just today. It's been quite a challenge. And the time suck is big. So, it's the paperwork initially, and then it's all the back and forth to get that paperwork seen by the right person. We tend to generate a very large office note with each visit, and I could send that for the first time and then send it on appeal, but it gets lost, and then send it again for appeal, and that gets denied, and then I could send the same letter again, lost, and again, and then it'll go through. I haven't changed any of the information or specified anything differently, so I'm quite confused by the process, and it feels like extra steps for no good reason.
And sometimes that's a 30-day script. So you're spending 6 days of that 30 days just...
Well, that's been the thing that's interesting for me. Typically, in other drugs, I've worked in cardiology for a very long time, it's been an approval for a year or 6 months, but then lately I've been getting approvals for 30 days so that we could restart the prior auth clock again.
For sure, you have to redo it every year. Yeah. For sure, that's a given.
And at the HCMA, we've just recently started tracking access issues to myosin inhibiting drugs, both scripted and in trials. Mm-hmm. What are some things that you would put on those lists? What are your top issues that we haven't discussed yet? Anything that pops into your head?
I will say every patient who's come, who's needed myosin inhibitor therapy, I don't want to jinx it, but we've been able to get it for the patients, and that's been a lot of work and a lot of time from our team. But we feel that that's our role here. I think that the access issues really are overcoming the cost and navigating the system and being able to kind of put up with that process. Like I think Sue said it best when she said, we tell people it's going to be so much, it's going to be so much. They kind of laugh, and then like a week in, they're like, you weren't kidding, no one will leave me alone. I'm trying to do a business meeting, I'm trying to work, I'm trying to do this. But just kind of staying focused on the goal of feeling better and really improving this disease that has no other treatment option quite like this.
And Sue, we don't want to make this seem like it's like an impossible thing. We want to provide patients with hope. And we're hearing stories of good results. What do you do to educate the patients on this new medication and kind of set expectations for a baseline?
Well, again, we do go over, the steps required, and I think it's important for the patients to know that they're part of the team getting the medicine for them. We tell patients, we will get it for you. It may take a while. And I think it helps when they know someone is on their side and is interested in helping them to feel better.
Well, and as a patient and as a patient advocate, I want to just thank you both for your work in putting together the full gambit of education and overcoming hurdles to something that increases quality of life. And I know it doesn't always increase your quality of life. So it's important to recognize that message. We only have a few minutes left, so I just want to see if we have any questions for the audience for Amy or Sue. Got a question down front?
Is this on? Okay. I'll ask a very simple question.
having lived through the last REMS, which was a drug called dofetilide, which had special certification for the prescriber, limited dispensing from pharmacies, and is no longer in effect. So I have a question. Does this work? Does a REMS work? And should patients be asking if REMS works scientifically?
I don't know that I'm the right one to answer that, as I don't think that the data of how many people have been caught in REMS of having like a correct stop or delay in therapy from a safety aspect. I've asked for that data, but it's not yet published or available. So I think that that's a hard question to answer at this juncture. Yeah.
And I know that the REMS program hasn't been carried over internationally. You know that as myosin inhibiting drugs are released globally, that the processes are different. But it's a good question for the patients to ask, and it's an important question to ask because we're seeing the downstream effects daily. Anybody else? Any other questions from the floor? All right. Well, we just have a couple other things that we did not catch. As other myosin inhibiting therapies or other new therapies come down the pike for HCM, which is wonderful, what are you going to be doing to educate the patients as far as continued care plan? You know, are you seeing any changes of baseline management because of these myosin inhibiting drugs?
At this point in time, we're doing the same general management and education, but now giving options. So that's really what we're finding, like that the myosin inhibitor therapy is a reasonable and actual option in real time now that people didn't have a few years ago, and that there is hope for advancement in this space and in this disease where I've worked for a really long time and we never had something that we thought might be a disease modifying. There's hope that we might get there now.
Great. Well, we're at time. I thank you all, and thank you for coming. I think Ryan's going to wrap it up.
For final thoughts, please welcome back to the stage Ryan Guj and Dr. Dharmesh Patel.
Well, go ahead. No, you go ahead.
We practice, as you can see.
Yeah.
So I'd like to say Ryan and Alison and the whole Patch team, Chris, Amanda, everybody, it's a fantastic event today, so well done. Secondly, the reason we're all here is because of the patients. So all the patients who've come for the CLA meeting and who are still advocates, the reason we are all here is because of you. And between the healthcare professionals and the patients and advocacy, Ryan, we really hope that we can make a change. So,
absolutely. I'll just say, first of all, I want to just thank our panelists for being here. You know, it is a major commitment to take away time from practices and daily lives to come and share their voices here in DC. So to all the panelists, thank you so much for being here. Likewise to the patients for spending the weekend with us, and they're going to go to Hill with us tomorrow. With that wraps the 6th annual summit, and Dr. Patel and I are headed to the Hill. So, okay. Thank you all. For the CLA patients, if you can just, Allison's saying we have to hang out. So the CLA patients, if you can just stay by. Everyone else is released according to Allison. All right, thank you. We know the stakes are high. Cardiovascular disease continues to be the #1 killer of Americans.
We have more options, we have more devices, but the disparities are persistent.
If a patient is stable on their medication, no matter what that medication is, let them stay on it.
Action happens when the public demands it.
The most powerful person in this room is the patient.
Patient-physician relationship is everything.
We just need to keep advocating for what is right.
Our goal is to take the experts who have devoted their lives to helping people with cardiovascular disease and elevate their voices in policy conversations at the state level and on Capitol Hill.